let's go ahead and get started again, and we can stay on time with the committee. We have some other committee members that have arrived now from other committees, and no, they haven't left yet. Lynn, you want to introduce yourself, and then Penny, if you'll introduce yourself.
Good afternoon, everyone. I'm sure y'all will catch me up on what you've done so far, but I look forward to serving here. I really feel like I'm in high school and the bell rang. I was in another course, another instruction, another study committee, and now I'm for this one. Looking forward to it. Thank you.
My name is Penny Houston. I represent Berrien, Cook, and part of Tift County. And I thought they had moved Statesboro when I drove over here this morning, but I think it took me a lot longer than I thought. But I'm sorry I'm late, and this is a great committee, and I'm so proud of the work they've done in the past, and I'm sure this year we're going to see more great work.
Thank y'all. We're glad that y'all have got here as well. We're ready to move on now. We go into the Department of Community Health. And I think we're going to start with our commissioner. And we're just delighted to have you here, Russell, and thank you for the work that you're doing. And then you can introduce your individuals.
Yes, sir. Well, thank you, chairs, Jackson and Green. It is an honor to be down here today, and I want to thank you for first of all, the invitation for your Department of Community Health to be a part of this, and thank you to the House staff that helped put all this together. I know it doesn't magically just happen, so thank you for all the work you guys have been put in with us and helping us coordinate all of this. But yes, my name is Russell Carlson. As of August 1st, was very grateful and honored to be appointed by Governor Kemp to serve as your commissioner for the Department of Community Health. We are presenting today by invitation, and we're grateful for that, to present a state of rural health from a DCH perspective, but with a particular focus on the financing component of this, along with some nuances about classifications and designations, to talk about not only the programs we offer, many of which are run through our great team in Cordell, and Nita and Dawn will be presenting here shortly, that have a 365-day focus on rural health. And I hope you can see that what I've seen all along, how responsive they are and how committed they are to working with your rural hospitals on improving their status in so many ways. But we want to walk through a couple of different programs. Like Anna mentioned, the Rural Hospital Tax Credit and the Rural Hospitalization Grant Program, but also the 4 directed payment programs that obviously have a rural nexus, a lot of dollars running through those programs. And they like I mentioned, have a rural nexus, but also affect the DISH program. And the main thing with these programs is not just what they are and what they do, it's the interplay of all of these programs choreographed to hopefully positively impact rural hospitals' bottom line. But also we feel out of transparency to show you a little bit about what they do and what they don't do, what they cover and what they don't cover, and the net impact at the end of the day, once all these programs have run their course on any given year, what the status of many rural hospitals looks like from a financial perspective, to let you, again, know a little bit more about the programs, but also when all these programs have done their work, where does that leave rural hospitals in Georgia? We're very proud of the work. And to give first an overview of the directed payment program, Joe Hood, our state COO, who's been in state service for a long time. As I say, one of my first meetings in state government in 2006 was with Joe Hood when he was the comptroller of public safety. And he told me that no then, and he's been telling me no for like 16 more years. But that's his job, to keep my dumb ideas in check. But I know we're sensitive to time, and so I'll hand it over to my friend and colleague, Joe Hood.
Thank you, Commissioner. So we've got a teaming approach to today. So what I'm going to do is go through the first slides, and then I'm going to turn it over to Dawn from the Office of Rural Health. And then she's going to turn to Nita, and we're going to cover 3 different topics. I'm going to start with the directed payment preprints and some comparisons of how these are complementary programs. And then Dawn is going to talk about the rural health tax credit in particular, in detail, and how that has, what technical assistance is provided there through the Office of Rural Health. And then we're going to finalize with the stabilization grant and from Nita on the end. So I'm going to start out with just the overview. What we really wanted to bring to focus on this presentation was some clarity and how these programs are complementary, particularly to the rural hospitals. So everything that you see as we go forward is on a rural hospital basis. We've tried to take the aspects of what the direct impact is to the rural hospitals and what it is not, as the commissioner stated. And so you have clarity so that when you have talking points on any individual subject, that we are talking, correctly and in detail about how those work. This first slide is just the overview of what you already know. It's all of Georgia's 67 small rural hospitals and critical access hospitals. And we have one critical access hospital that's in a non-rural county, that's in Effingham County, that qualifies for DSH. So we point that out, that's included in our discussion here. And then we have, as we've talked already, one rural emergency hospital, one designation in Irwin, and 54 counties with no hospitals, as y'all are well aware. So we have, we have some deficits in rural Georgia there as well. As the commissioner talked about, we wanted to define the Georgia Directed Payment Preprint programs. Y'all may have heard quite a bit about preprint programs, or DPPs, for Medicaid. In last session, that was our first year that we had gotten that approved. It's over $800 million net dollars on the federal side that we bring to Georgia. And it's a combination of these different programs. And we wanted to have a slide that defined this for a leave behind so that y'all can clearly have it, and certainly we can speak to it. The first one is Georgia Aid. That is Georgia Advancing Innovation to Deliver Equity. This is an at-risk program that Grady is now the only beneficiary because of the designation change for Augusta University going to Wellstar. But that's a huge effort, several $100 million that Grady does independently, where they get Medicaid rates advanced up to a percentage of commercial payers to bring in additional dollars. And I do think it's important on all of these to understand, I had an audience, that what we're doing on almost all these supplemental payment programs is we're just raising what the Medicaid utilization payment is for those hospitals up to a commercial rate. So it's a different percentage depending upon what the eligibility is that the Centers for Medicaid and Medicare have approved for us. But that's what we're doing. So it depends upon the hospital's utilization for Medicaid billing, and then what the percentage is that we're allowed for them to bill for those claims for Medicaid during that time frame. So the second of these is Georgia Strong. Georgia Strengthening the Reinvestment and Necessary Workforce in Georgia. And that is for our teaching hospitals primarily. And the emphasis is on enhancing the workforce, to use those dollars to continue to bring growth to the physicians' workforce that we have through those teaching hospitals. Then we have physician-directed payment preprint, which are physicians that are associated with an academic program, such as a GME, a graduate medical education program. And then lastly, and the most important for rural, is hospital-directed payment preprint program for rural acute hospitals, which includes the general cancer, freestanding children's, and rehab psych. So the critical access hospitals are excluded here. What's not on the slide, and you will see later in some of the slides that I have, is disproportionate share. And while disproportionate share is not in of itself a new supplemental program, it's important to note that with the advent of Grady coming in to aid and qualifying for this aid program, that took $100 million out of DSH that Grady was receiving, and we were able to add that back and prioritize rural hospitals so they get much more disproportionate share money than they did previously because of these programs that allow Grady and others than the teaching hospitals to receive these programs. The next slide is just a summary of what these programs specifically provide in Georgia. We have Georgia Aid for Grady, because of the dish, we've got that to the side. There's not a rural hospital because only Grady is the eligible one there. Georgia Strong are the teaching hospitals, and there is one, and that's denoting that 15.9 million there. And then we have the 24 public and private rural acute hospitals, which benefit from payment preprint programs of about $63 million in totality. And then we have the physicians group, which is one rural hospital has a teaching program, which is benefited there for this $5 million. So a total of $495 million. And then this is just a map that illustrates where those facilities are. And you've got the aid are in Georgia and Augusta, which are not rural, of course, but are creating that dish waterfall that we talked about. Then the Georgia Strong hospitals are the teaching hospitals. We have one in rural Georgia. You can see that's blue highlighted in the green. That's our only one that's benefiting from that directly. And then we have the HDPP, the public and private, which is the light green. And you can see we have a variety of public and private acute care hospitals, 37 in total that are benefiting from that. On this slide, what we're trying to do is to demonstrate how much money in comparison there is that comes about from the payment preprint and the rural hospital tax credit hospitals. So we've taken an average of 50 rural hospital tax credit hospitals that were of benefit that we had all the data for to create these slides. And you can see that the DPP and the DISH add up and have the comparison. But when you compare to the donation level that was in this last fiscal year, you can see that the rural hospital tax credit alone had $58 million. And I think Anna had a great presentation point earlier that we're already up to near the cap this year of $72 million in donations. So it's just a talking point to give you perspective that even though the payment preprints for rural hospitals are beneficial and they provide an amount of funding, this $34 million, in comparison, you know, last year the rural hospital tax credit as a complementary program was much greater than that, and where we are today is even further still in the amount of revenue it brings to rural hospitals. This slide is to talk about the cumulative effect that still exists. So what we've done here is we've added all the revenue that we have from payment, preprint, and DISH impacts that we received that are on the left in the blue, and we've got them delineated here in the different colors, and they add up to the $187 million for rural hospitals. But on the right-hand side in red is the qualifiers for the rural hospital tax credit. And that's, you have indigent care, you have charitable care, and then you have bad debt. And when you look at that, that gap, as you can see, is still tremendous for these 50 rural hospitals that are in this data that we compiled from last year. So even after that's received, we just want to make sure that there's no misnomer that this doesn't solve rural hospitals' revenue problems, right? We still have a huge gap to when you look at that comparison on what we have as qualifiers for the rural hospital tax credit in comparison to the revenue that we have brought in. Even though we're very happy to bring in new revenue, we want to make sure that y'all recognize there's still some issues to address, which after this morning, I know that you're well aware of. This next slide is a more illustration point of that. It's a before and after. So before the DPPs and then after the DPPs, and you can see those pie charts look very similar, and that's because there's only about 1.5% difference in before and after. So it's a large dollar amount, but we've still got a lot of bad debt, indigent care, and charitable care that exist after that is in place. Then we wanted to provide this slide here to give you an average. Because, you know, when I do these big numbers and we talk about the hospitals as a whole, I know that many of you have individual hospitals and you're like, well, from a talking perspective, what are we really talking about on average for an individual hospital? So we've broken that down for these 50 hospitals that we had the data for that were in rural Georgia in the tax credit program last year. And we've lined them up on average what they would be. And you can see we've got the preprint program, which is primarily from that HDPP program with the 37 hospitals. Then we've got the DISH impact that's beside that. And then we've got the rural hospital tax credit on average. And so those are all our revenue streams. But then again, I break out on an individual level. On average, we have over $10 million in bad debt. We have over $4 million in indigent care and over $2.7 million in charity care. So this is just illustrating that gap for you on an individual basis of what still exists with all the revenue streams that we have in place today. And at this point, what I'd like to do is turn it over and let Dawn talk to you a little more about the rural house tax credit individually and what it has meant from her perspective. She's providing technical assistance to our rural hospitals and helping us move that program forward.
Thank you, Joe, and thank you for having us today. We are excited to be here to share a little bit more about what we offer in Georgia at the Department of Community Health. For the Rural Hospital Tax Credit Program, in calendar year 22, rural and critical access hospitals received a total of $58,732,411 in rural hospital tax credit funds. The average funding per hospital was over $1 million. The largest donation was just under $4 million at $3,996,999, and the smallest donation was $66,846. And so the benefits of the tax credit program are that hospitals may use the funds as needed for personnel expenses, for regular operating expenses, for payments to reduce long-term debt, for motor vehicle purchases, for equipment purchases, capital expenditures, and for contracts. And as Anna shared earlier, some stories about what our hospitals are using these funds for, some other examples from their reports include physician and surgeon recruitment and retention, to reduce burden of uncompensated care, to cover increase in employee health insurance, for bad debt expenses, for computer system upgrades, which is very important, for a medical education center, for a Jerry Psych unit, for a psychiatric center, for day-to-day expenses and payroll, for oncology upgrades, to recruit a surgeon and upgrade a surgery center, to expand outpatient and ED services, and for fetal monitoring and ultrasound equipment. So these are great examples of the expenditures provided from the Rural Hospital Tax Credit Program. And there are 52 rural hospitals that are eligible to receive 2024 funding per the 23 preliminary eligibility list. The anticipated funds are $75 million, and the estimated average per hospital is $1,442,307. And as Anna mentioned earlier, and as we've heard, this program is scheduled to sunset December 24. And as Joe mentioned, the State Office of Rural Health has been assigned the task of providing technical assistance to our hospitals to in their submission of their tax credit donation and expenditure reports. And we'll also draft the tax credit donation and expenditure summary reports going forward. And so I am the technical assistance contact for those for that assistance for those hospitals. And here's my contact information. And so next I'm going to turn it over to Nita Ham, who will come and give us an overview of the Rural Hospital Stabilization Grant funding and the impact on rural and critical access hospitals. Nita?
Thank you very much, and I'll echo my DCH team members' words that we're so happy to be here today, and thank you very much for having us. So as Dawn said, I'm Nita Ham. I'm with the State Office of Rural Health, and I manage the Rural Hospital Stabilization Grant Program. So I wanted to tell you a little bit about this program and the wonderful benefit of this program to our rural hospitals. Our rural hospital leadership tell us frequently that they so much appreciate this program and they are so grateful to have these funds. So this program is a legislatively directed program, and the first year of this program was actually in fiscal year 2016. We are currently in the 8th year of funding with this program. We have recently kicked off the 8th year with the FY23 funds. So those grants were executed June 30th. And so most of the project period will actually be through fiscal year 24, but they are fiscal year 23 funds. So currently with this year of funding, we have 8 hospitals participating, and the award amount for those hospitals per site is $875,000 apiece. Through the 8 years of this program, we've had a total of $46 million that have been provided to our rural hospitals. There have been, through the 8 years, a total of 64 awards. 35 of our rural hospitals have participated throughout the program, and 20 out of 35 of those rural hospitals have actually participated in the program during more than one funding cycle. And that means that a little bit over 50% of our rural hospitals in the state have actually benefited from this program. The map on the left actually shows you the counties in which these 35 hospitals reside. So the funding amounts and the number of hospitals that have participated have fluctuated a little bit through the years, but the average award amount is actually around a little over $718,000, and that's the average award amount per hospital. Remember, we have had some hospitals, 20 of the 35 that have participated in more than one funding cycle. We did a program analysis on the first 5 years of the program, and we actually determined that the award range between $750,000 and $900,000 per grant award actually supports initiatives that have the best return on the investment of those funds. So in the last few years, the Department of Community Health has used a competitive application process to award this funding. And our hospitals have shown a terrific increased interest in these funds. For funding year 7, we had 22 applications for that funding cycle and only 10 awards available. In funding year 8, there was an increase. There were 28 applications from our rural hospitals and only 8 awards available. Based on the funding that we now have in the budget for fiscal year 2024, it looks like we may only be able to support about 3 awards if we're staying within that sweet spot of $750,000 to $900,000. This is a bar graph that actually shows you the funding per year for all 8 of the years. We had, for all 9 years rather. So the first 5 years, we maintained funding at $3 million per year. And in fiscal year 2021, we actually had a bump to $15 million for that particular funding cycle. And we were able to fund 16 hospitals participating in that particular cycle at $881,000 apiece. The funding dropped in fiscal year 22 to $9 million. It dropped in fiscal year 23 to $7 million, which has dropped the number of hospitals that can participate in the program. And then our funding for 2024 has dropped to $2 million. We have a lot of oversight for the program. So once the hospitals are participating in the program, they do have specific requirements for their use of funds. They submit proposals to the office. We review the proposals to ensure the way they are choosing to use the funds actually meets those funding requirements. And the box on the left is an example of how many of these hospitals have chosen to use their funds. One of the things that we've realized is our rural hospitals are very different one from another, and the rural hospital leadership really is the best team to allow to choose how to use those funds. So the box on the left is almost a mirror image of what Dawn presented to you earlier about the use of tax credit funds, and it also mirrors what Anna presented earlier, because many of the projects that Anna presented that we're funding through tax credit funds are very similar to projects that our hospitals use with their stabilization funds. So this is sort of a summary slide as we are getting near the end of this presentation. It just compares the totality of these programs. So the DPP program, the Rural Hospital Tax Credit, and the Rural Hospital Stabilization programs. As you can see in the column specific to hospitals, the tax credit and the stabilization program, as well as the DPP program, really allow those rural hospitals to use these funds, and tax credit and rural hospital stabilization are available for our critical access hospitals to use. So just to personalize it a little bit, our office works very closely with rural hospital leadership, and this is just some pictures from some of the meetings that we've had in recent years with our rural hospitals as we're working with them on the tax credit program as well as the stabilization program. And that brings me to the last slide that I have, which is just the contact information for all of us that are here in front of you today. And at this point, I will turn it over to Commissioner if you want to have any parting words as we summarize the presentation.
No, thank you guys for this presentation. I know we're going to be bumping up against time shortly, and we also want to open up for any questions you might have of the group, but also I want to be clear, chairs, we intentionally are not going anywhere, and I don't want to eat into anyone else's time, but we are office hours outside as long as you need us this afternoon for anything that might be specific to your district or things that you like to pass along. So we'll be here all day. So
Thank you, Commissioner. We've got a couple of questions. Representative Perkle.
Thank you so much. Commissioner, I'd like to see you offline, and I've got a couple of things I'd like to run by you, but I do have a question for Mr. Hood, if that would be possible. So regarding the money slide that you showed,
Yes,
that shows the number of indigent, charity, and bad debt for our rural hospitals. So I have 3 kids. And when I would ask them, how are you doing in school? Invariably, they would say, pretty good. Well, pretty good for the oldest was far different than pretty good for the youngest. They had different scales. So it's my understanding in hospitals, billing is somewhat of an art. So the same procedure will be billed at a rate for a provider. It'll be billed at a different rate for provider B and billed at a different rate for indigent charity care. When you look at a $10 million bad debt, $4 million indigent, $2 million charity, which kid am I talking to? So is it, do we have an idea that this is at cost, or is it cost plus? It is at commercial rate? Is it, or do we know?
I'm going to give you my educated guess without, and realize that's what it is. And we can certainly dig into it to the extent we have data. But what I understand that to be is most likely the difference on where someone perhaps has a commercial payer and they've come in and they've got a deductible. I, for example, went to the ER recently. I've got state insurance. I got a bill in the mail for $1,500 for that ER visit. That was primarily the bulk of that visit. And I owed that. But I suspect that a lot of this debt comes from uncollected bad debt. And then we still have a lot of uninsured. We had it presented earlier, and I really took note that in rural areas, we have 21% that are uninsured. So, but I know the key to your question is, how are they booking that bad debt, right? What amount is it booked at? And I think it's probably dependent upon what the scenario of how it was created. If they had an uncollected bad debt where they collected a portion from the commercial insurer, it's whatever their contract would be with that commercial insurer for that rate. And then whatever the difference was that they were supposed to collect from the insured that they didn't pay or partial paid, that's going to bad debt. If it's an uninsured person, it's going to depend upon how they're booking, what their policy is for a hospital on what their rack rate is, if you want to use that term, for that. And I think y'all are all familiar. I mean, I think about hotels, right, when I do rack rates, and you can look at the back of the door and it says $500. And, if generally that's when I was talking about Augusta National with someone earlier that they had tickets to Augusta National. For that weekend, it is $500, right? But if you go there today, prior to that, it might only be $100. So it's all depends upon what the contracted rate was with that individual that they booked into that into that and what was not collected.
And that's kind of what I'm getting, if I can follow up.
Sure.
And so that's kind of what I'm getting at. So my room rate tonight, because I was tardy in getting a room for tonight, it's $325. Some of us who were smart and got in on the front end might pay 150, 157. So the Tylenol, so 2 Tylenol that is going under commercial payer might be $20. If commercial covers only 50% of that, then my question is, do they write off $10, even though they collected 10, while their cost is 5 cents versus any of the other provider scenario? And and I know it's the data is only as good as what is presented to you, but I don't know that we have a good handle. I don't. You might, but I don't have a good handle for.
Well, I mean, the answer is varied, right? And that's the trouble that
still
you're having
important.
is it depends upon what they booked it at. I assure you that what they're writing off on bad debt, if they had an agreement for $1,000, they collected, 500, and then they were owed 500, they're writing off $500 from an accounting perspective, and that's what's in that number. So it's all depends upon what the contracted rate was for that individual for that service.
And then we'll let Patty introduce herself. Okay, Chairman Hatchett.
Thank you. Come on.
Smash your button.
There you go. Hey. The lights on. Come on. There we go. So thank you, Joe and Commissioner Dawn and Nita. The rural hospital tax credit. Several years ago, we tweaked the formula for eligibility of the hospitals. My question is, are the hospitals still comfortable with the formula that says which hospitals are eligible? Are there some tweaks that might need to be made? What are the hospitals telling you? That's my question.
So it usually depends, Mr. Chairman, on whether or not they are eligible or not, to be honest, which is not a surprise to you, I'm sure. Most of them, I think, are fairly comfortable if they retain eligibility. We had a number, I think you may have seen that our number on eligibility varied between 55 and 50. And we've had, 4 or 5 who have been on the bubble of qualifying on this 10%. So there's in the statute that creates it, there's this 10% qualification that you have to show of a combination of these 3 areas to qualify. So I think for the most part, to my understanding, and Anna may have a different perspective from the Hospital Association, which I would welcome to this question, but from my understanding, unless they're on that bubble and whether they may not qualify, then that's a question. For example, we've got to deal with the emergency hospital that was talked about for legislation. Do they qualify for some other programs now that they don't have inpatients? So I think a lot of those kind of tweaks we do have to look at. And what's y'all's intent, right, to continue forward with that type of eligibility?
So if they're eligible, they're fine. If they're not, they're not, right?
Yes, sir.
But historically, isn't it fair though that the criteria hadn't shifted? So it's been pretty constant, steady that the criteria hadn't shifted enough to where you're having, swings
fall off, a
of
cliff
10
fall
or
off.
12
Okay.
that might, as you said, even when Joe referenced the variance, it was between a 50 and 55 measure. So there is a degree of predictability on criteria.
Absolutely.
Representative Taylor.
Thank you, Mr. Chairman. I had a couple of questions, but I do appreciate all the great information y'all have provided today, and I know you work very hard. It actually has to do with the slide that's up there now. Do we have any idea what the type of care and incurred charges are for these? Was it inpatient, outpatient? Was it surgery? Was it what kind of care and diagnoses? So we can then plan, do we need to have more outpatient doc in a box? Do we have to have something? I'm trying to figure out what was incurred in those.
So this information comes from the hospital survey that our planning entity does at the Department of Community Health. That's how that is pulled in. I believe that it at least the way that we see it, is in a summary manner that it doesn't really get to your question, Madam Chair, where we could answer that. We certainly have other claims data on Medicaid where we could look across the spectrum at any individual question you might have in that respect. But this in particular is really at a summary level. It's self-reported from the hospital on the survey and then tied to their financials. So it really doesn't get into the claim-based nexus to give us that type of information that you're asking about.
Would it be a terrible imposition to ask them to break it down that way? Because I do think it's important to know what kind of, is it inpatient major heart surgery? Is it an outpatient skin knee?
I understand. I will say there are challenges, and Dawn can talk to that maybe more so than us. We are audited almost every year on this from a performance basis by the Department of Audits. And I'm not going to say it's too much of an imposition, but I'm just going to give you perspective. She had, I think, over 30. How many hospitals did you have to correct? 38 hospitals that the Department of Audits pinged us on that we had to go back and make technical alignments with and work with those individual hospitals to get their reporting correctly for the audits. So while there just are challenges there as everywhere with trying to get those surveys correct, we had to go back and make eligibility edits. Last year, our director of rural health, he pointed out that 3 of those hospitals that were on the bubble, they were eligible because they didn't classify revenue correctly. So given staffing and everything that is there in a rural hospital, I will say it's challenging for them to do that. We've got our Office of Rural Health, particularly have designated Dawn and her team to try and help with that. But there are challenges from a technical aspect, just because, as you can imagine, what the staffing looks like in those facilities.
If I could follow up.
While this won't be the granular answer you're looking for, I do believe as far as an overarching takeaway is what constitutes or what drives that number. ER visits in general
Sure.
obviously is a big piece where the catalyst for a lot of this. Now, what services kind of ultimately come from that, but as far as one takeaway, behaviorally speaking, what gets there is ER visits are a main driver.
Is it consistently like this, or is this affected by COVID, where we had a lot of people all of a sudden sick and didn't have
I
coverage?
believe it's pretty consistent.
I would think it's pretty consistent on a 30. When I look at the rural health hospital tax credit ratio, 10% is the qualifier. Most of them have been at 30% or better on average for most of the time frame we're looking at. Now, we didn't do a slide to that effect. This is the most recent year. So this is really 2022 is what we have this data from.
Okay.
So just to give you that perspective, but I think it's been fairly consistent. And you did the right, Cross?
Okay, and if I could have a follow-up? It had to do with the rural hospital stabilization, and there was such a change and a drop of the funding. I'm curious, did you just request less money, or did we just cut it? Well, I would kind of like to know what caused that great change.
So the grant is totally at the will of the legislature. We don't have that as the person who oversees our budgetary request.
Yes.
We don't have that as a budgetary ask traditionally within the budget. It is something that comes to us from if the governor puts in a recommendation, or if y'all have additions or subtractions, that's just how that has flown. We have not advocated or made that part of the departmental budget request, just because generally we're looking at the Medicaid budget as a whole and those larger swings and those types of things. And it's really just been the discretion of the legislature about how that has come about. We've tried to be supportive with these types of Q&A so that you know what it does, but we haven't done it as an official request.
Thank you.
Last, we have Representative Jason Ridley.
Thank you. I'm not smart enough to ask you any hard questions like these other folks, but one thing on that slide there that showed like the Georgia Strong, the different stuff. Tell me, what is the governmental teaching hospitals? Can you give me an example of what that is?
Of what a teaching hospital is?
It said governmental teaching hospitals.
Well, so there's 2 classifications of a hospital generally for these programs. One is public. So generally that means that it's a hospital authority that owns and operates that hospital. And then there is private, and generally that means that it is privately run. It may be a nonprofit, but it's still privately owned and operated as a nonprofit and not owned by a hospital authority. at the county level.
Okay.
Generally, that's what you're looking at.
All right, thanks for clearing that up. And the next one on where it shows like well, I guess what they can spend it on, the list there, the personnel expenses, I think Anna kind of explained a little bit of that to me, but how is that? Is there parameters and who audits that?
So there's general broad statutory parameters, and then the Office of Rural Health, when we go through, and that, certainly on a competitive basis, we look at that and we approve budgets based upon what they've applied for. But then we get audited to the extent that it's appropriate by, to those parameters by the Department of Audits.
Okay, thank you.
Thank you for the presentation.
Yes, sir.
Before we introduce the next group, we have former Representative Patty Bentley, who is now Representative Patty Stinson. Introduce yourself.
Good afternoon, colleagues. Good to see everyone. I am Patty Marie Stinson of House District 150. I've been serving in the General Assembly for 11 years and just glad to be here on the beautiful campus of Georgia Southern once again. So thank you.
Thank you, Representative. Ladies and gentlemen, we're getting ready for the Medical College of Georgia at Augusta University, right near Sandersville. Margie.
You're sick.
Dr. David Hess, Dean of the Medical College, will introduce his staff.
Thank you very much, Mr. Chairman. There'll be 4 of us here. We'll do a quick tag team, and I'll introduce them as we go. So thank you. We have a lot of information. This is our white coat ceremony we have every year where the students get their white coat. How do you know when it is? It's always the Saturday before the Georgia-Florida game when people will come. So if you want to know. We're the 13th oldest medical school in the country. That building there dates from 1833. So we're old, but we're very innovative. This is a map that almost looks like the map of the critical access hospitals. It could almost superimpose it. These are where there's physician shortages. If you're yellow or green or even blue, you're short of physicians. So it's almost all of Georgia. It's particularly, of course, in the rural areas. This is the Georgia Board for Healthcare Workforce. This is the reference. And as you can see, we have, this is very important, Chad Reyes here, 82 counties without an OBGYN, and we rank 49th in the country in maternal mortality. I mean, that's not the whole explanation, but it certainly is part of it. We have many counties without a physician. We're short of just about every specialty you could imagine. I don't know anything we have enough of. Now, MCG is the state's only public medical school, and we have regional campuses. So right now, you are in our Southeast campus. That's where you are, if you didn't know that. And we have a Southwest campus headquartered at Albany. The Southeast campus is Savannah and Brunswick, but we have students, rotating in Statesboro. Northwest, we have Rome and Dalton. Northeast, we have our partnership campus with UGA. And we call the Middle East Augusta. And these are some of our, these are not our partner health systems. We have a number of partner health systems that are not shown on this slide. So we are all over the state. All those white dots are where students rotate. So we probably have the best coverage of any medical school in the country of the whole state. We also have a very innovative curriculum. I told you we were old, but we're also very innovative. We now have a 3-year medical school. Mercer has a 3-year option, but you can now graduate in 3 years. But we have other options, which I don't have time to go into. We have a very tailor-made, very interesting curriculum that's comes to everybody. They could do a research track on the right, or they can get a dual degree. They can get an MBA or a Master's of Public Health. So there's a lot of options, but I'm going to focus on the 3-year curriculum. The reason we did this in 2020 was to get students out and reduce their debt. So we have one of the lowest tuitions in the country. It's about $30,000 per year, but our average student debt is about $170,000. So students still have, and that's just medical school. That doesn't include debt from undergraduate. In this 3+, we call them Peach State Scholars. We get a big donation from Peach State Health, which thank you in this room, the state of Georgia matched, and then you matched another year and our foundation put in some money. We now have an endowment of about $40 million to pay the tuition for students who go through medical school in 3 years, do their residency in Georgia, that's a requirement, and then have to practice in underserved Georgia for the number of years they get the tuition scholarship. So it's usually 2 years of scholarship, so they have to serve at least 2 years. So this is what we call scholarship for service. We've had our third class selected right there. There's 8 students in that last class, and the first class is already in their residency. I'll show you them later. So again, this is thank you to the state support. This is a public-private partnership that's been very successful. And we're going to have all these students going to medical school in 3 years who are committed to practice in underserved Georgia, all those yellow and green areas you saw on the first slide. And here's our first class. They're now doing residency at Georgia. Residency is anywhere from 3 to 5 years. They have to do something we call primary care, which is probably defined as internal medicine, family medicine, OBGYN, psychiatry, pediatric surgery, and I forgot one, emergency medicine. Emergency medicine. Thank you. That's why I have my helpers here. But they're all doing very, very well. And so this will be the first class that goes out into rural Georgia. And Claude on the left is from Columbus. Luis in the middle there is from Tifton. And that just gave you some examples. They generally come from rural areas. Now we're also enlarging the size of our class. So we have 264 students this year. That's the 9th largest medical school in the country. But we're going to be probably the 3rd or 4th largest medical school next year when we open a campus in Savannah. I'm going to get to that in a minute. So a very, very large medical school. 304 students per class is very, very large for a medical school. A lot of medical schools have 100, 130, 140 students. We have a very large one. So we're old, we're innovative, and we're large. You got that? Now, this is exciting. Fortunately, I want Elizabeth Gray to stand up. This is our campus theme for Savannah. Elizabeth has grown the clinical campus in Savannah. We've had a clinical campus in Savannah for over a decade at St. Joe's Candler. There's Paul Hinchy, the CEO, and Dr. Julia Michael, the CMO, who's an MCG graduate. They've been extremely supportive. While at Spacer, though, our students go all over. So Elizabeth Gray was doing so well. So we said, Elizabeth, can you do a 4-year medical school in a year? And she always says yes. So we're going to, in a lightning fashion, probably start this campus really, really fast. And the reason we're able to do it is, next slide, is the wonderful support of Georgia Southern University. I knew I'd get a head come up, and President Marrero, and the provost and all the people at Georgia Southern who have really reached out and worked together. President Keel and President Marrero have worked very, very well to this partnership campus. So it so happens that the Armstrong campus is right across the street from St. Joseph's Hospital. It's perfect. And they have this beautiful health professions building, which they're sharing some of the space with us, and they have other space there. So we got a paltry, really, $1.7 million, which we thank you so much for approving that. But we're $1.7 million, we're basically doing these renovations to have a campus. That's a really low price to start a new medical school campus. And that's just because of the cooperation of Georgia Southern and Elizabeth Gray, who's walked through it. So we're going to do some renovations. They're in progress now. They should be done by June or July. And we're supposed to have our next class in July. So the good news is, if you have somebody applying to medical school, a friend, a loved one, family member, we now have 40 more slots. And they can choose the 4-year campus between Augusta, Athens, and Savannah. That's a great choice. Now, one of the things we have a problem with in Georgia is residency slots. We had some questions about GME before. Well, in GME, unfortunately, we rank, here's another bad number, 40th in the country in residents per capita. And our state is growing. And the states around us, Florida and South Carolina, the other states in the Southeast, are ranked much higher than we are. Okay? And, I think some people were asking about GME funding. That would take a whole hour to go through. It's arcane. It's difficult to follow. The rules are rather Byzantine, and it's funded mostly from CMS and Medicaid, but we're way far behind. And so because of this, we're a net exporter of medical students. We export medical students everywhere because there's not enough quality and enough GME slots in Georgia. So our residents, and it's great when they go to Harvard, it's great when they go to Johns Hopkins, but we hate to lose them all to the Northeast and the Midwest. Because you know what happens when they go up there? They marry someone from up there, and then we're finished. We'll never get them back. As a New Jersey immigrant, I can tell you, I don't know why they would live up there, but they do. But if they get a spouse, you know, that's where they're going to go. So we got to keep them in Georgia. So if you go to medical school in Georgia, your chance you're staying long-term is about 30 to 35%. If you go to medical school and you do your residency in Georgia, it's about 60 to 70%. And of course, our Peach State Scholar, it's 100%. At least they're going to stay for a number of years. So we got to get more residency slots. And the feds, we have caps. Many of our programs are capped. And Butch Parrish and I were just discussing this. Or you have a virgin program and you have 5 years to get your cap. But if you're capped like we are, we can never get any more residents from the federal government, except they did have this program called the Consolidated Appropriation Act of 2021. They only had 1,000 spots over the cap for the whole country. So that's like 20 to 30 per state. Now we got 2.44. Now how could you get 0.44 resident? I mean, but that's how it is. We wanted 5, we got half. And that's because we have a rural training program. We want to train the residents in rural hospitals. But the rural hospitals, as we've heard, they don't have the resources or the funding to do this. So one thing the state could do is fill up the gap for us in that funding to cover the rural hospitals, so we get more residents training and more residents training in places like Albany and Brunswick and Rome and Dalton, right? They're more likely to stay there. Where you train is where you tend to stay. Where you train is where you tend to live. So that's just one idea to throw out there to help the GME issue in Georgia. Because, you know, ranking 40th and the population's growing, it's going to get worse. As Georgia's just soaring in population, we got to keep up with the growth. And there's just so many hospitals that are resident ready. A lot of them can't do it. So I'm going to hold my questions, hold any of your questions till later. Who goes next? Is it Lauren or it's okay? You guys are going to come up together, tag team. So one of the great things is we have a great telehealth program at MCG. We have an MCG Center for Telehealth, and Matt Lyon, who's not here, and Lauren and Chad are big parts of this. It's a way to connect Georgia. We can't always have boots on the ground, but sometimes we can assist local physicians and healthcare, like rural hospitals, in managing the patients.
Okay, well, thank you for letting us present. I'm Lauren Hopkins. I'm the Assistant Vice President for Virtual Care and Community Engagement at now Wellstar MCG Health in Augusta.
I'm Chad Ray. I am an obstetrician gynecologist. As Dr. Hess indicated, people who train in Georgia tend to stay in Georgia, and that is actually me as well. I met my wife in residency and stayed at the Medical College of Georgia to start a career. I have been before many in front of this committee before, and know that this long commitment for me is about advocacy for population health, and that is really why I'm here today as an early adopter of this, which I think is really transformative for how we will deliver care in the future. There is a tremendous amount of effort moving toward virtual care. And I don't need to tell anyone in this room about the access crisis that we have in what is certainly 2 different Georgias. I think as, you know, my career as an obstetrician gynecologist, I saw 5 hospitals in just the East Central Health District close in the first 10 years of my time at the Medical College of Georgia. And then as that happened, I started to really understand workforce issues because it was affecting me on a personal level and then a professional level. I think that the rural hospital closure, while it affects certainly as an obstetrician gynecologist, the map that is shown in this slide shows that those areas in blue are areas that do not have a hospital within 30 miles of the inhabitants of that area in blue. And then those in yellow
that relates to the hospitals that have closed and not being within 30 minutes of that. So, nationally, this is a tremendous issue as well with 892 hospitals. And this has probably changed significantly even over the last couple of years, but Georgia has 26 hospitals that are at risk for closure, and that number is probably larger at this point. This is from 2020.
And one hospital we're going to talk about in a minute is Candler County in Metter, Georgia. It was the risk of number 2 in the state of Georgia in 2018 for closing. And we've been partnering with them since 2020. And we're going to give you some statistics in a minute about the program and how it's really transformed what their hospital and their capabilities and their census and financial stability. So in response to the rural hospital issue, and then also too, just in general, access to care in period, Dr. Hess and others at the Medical College of Georgia really believed in what we were doing through telemedicine. And telemedicine is not anything new. It's been around for a long time, but how you use it and how you apply it, especially in our rural areas, really should be looked at in a different way. And so we started the Medical College of Georgia Center for Telehealth this past October. And really our goal and our mission is to connect all patients across Georgia through digital means. It's digital inclusion and people connecting to people. And we do this through a multitude of ways, but our pillars are really right here at the bottom. Education. So how are we going to not only train our current learners, but future learners, future nurses on how to deliver telemedicine in their practice? Research. A lot of rural populations get excluded when you're looking at clinical trials. So being able to take our rural partners, put them in a research collaborative and be able to have them included will enhance their outcomes long-term through research driven by rural populations. Connectivity. Broadband's a huge issue. I live in Waynesboro, Georgia, and even yesterday I was talking on the phone with Dr. Ray, or attempting to, and my cell phone's going in and out, right? So we have connectivity issues all across the state, and especially in our rural partners. And so this is a key piece for us, is how do we ensure we can provide that connection to those hospitals? And then clinical operations. How do we support rural communities, enhance their care and capabilities to provide more complex care and keep patients in those communities? So for Wellstar and Medical College of Georgia, telehealth is a strategy. And that's really what we've been focused on since the pandemic, is really driving telemedicine as the use to connect patients back into specialized tertiary care. But most importantly, what we've really tried to do is how do we take that triple aim of reducing cost, improving quality, improving patient and provider satisfaction as well. And so with our program, one of the big keys we've looked at is how do we improve rural hospital sustainability? How do we keep patients there so we can increase their average daily census, increase their skill sets? By ultimately doing that, you're able to drive down healthcare costs if they stay in their community. No ambulance transfers, no helicopter transfers. It reduces that cost of care, not only for the patient, but it drives the cost back to our rural communities, which is great. And on the flip side, it helps larger hospitals like those in Augusta or Atlanta or Albany by not having that overcrowding of the hospital patients in your emergency department in your hospital, when those lower complexity patients can be kept and maintained in their rural community hospital.
So this slide will really outline where the tele-ED and CCU critical care hospitals are, the hospitals that are ambulatory specialty care clinics, telestroke hospitals, and telehospitalist programs. So you can see the state is pretty covered in relationship to the opportunities for us to do telemedicine. Telemedicine technology certainly connects populations to the academic medical center. I think Lauren really highlighted extremely well how connecting the academic environment to those in the rural communities really will drive how those hospitals are able to be sustainable, but also how the complexity of the patients that they'll be able to take care of in the future. And it really is a partnership. As it relates to, and this slide would certainly, if Dr. Lyon were here as an emergency medicine physician, and really the architect of much of this, he would tell you that the emergency medicine to emergency medicine piece of this telehealth network really is critical for having that level of care from the ERs that are in rural Georgia with the ER in the hub at Medical College of Georgia. You can see this outlines a significant number, I believe it's 16, is that right, Lauren? Hospitals that are in the virtual care network that also provide telecritical care. And so, when a patient presents, I think it's, this is the kind of opportunity that may change something that I have as many of you know, where you live is probably dictates how long you live. And I think that, unfortunately, for a lot of areas, this is always going to be true. But when you have a partner where you're able to access high quality specialty care in such a seamless, rapid way, that actually may be less true going forward.
So when we started the program, we started in 2020. We had a USDA grant that we were able to launch using putting telemedicine carts in 5 rural hospitals. Obviously in 2020, everybody's world and life changed. And by the end of 2020, we changed from what we were doing from an ER to ER only basis program to covering all the way from triage in the emergency department to discharge from the inpatient floor. So patients we follow them via telemedicine from admission to discharge. Why is that important? Well, it was very important during COVID when there were no beds available. Hospitals were trying to call all the way to Tennessee, Florida, wherever to get patients out. So we stepped up and started supporting these community hospitals by keeping patients in. We were rounding daily. We do still round daily. And what we did is we started adding facilities to the network. By adding the hospitals to the network, it really increased the numbers. But what it also too did was we started realizing where we had gaps in skills for these community hospitals and community providers. So in partnership with them, we began teaching them. We started monthly journal clubs to be able to enhance their skills. We did hands-on skills training. They actually came to AU to their simulation lab, did training there. And we did this so we could actually help support them, not just during COVID, but we recognized the need to continue this program outside of the COVID pandemic and treating other conditions, right? Patients didn't stop having heart attacks during COVID. None of that stopped. So you had to also be able to treat those patients as well. So what you see here on the screen is the statistics just from our fiscal year. And the reason that it's super important, what we've highlighted at the bottom, is that transfer rate. Prior to 2020, the hospitals that we partnered with, 80% of their patients would transfer to Augusta University for healthcare services, 80%. During COVID and even now, we've been able to drop that number, as you can see, to 27%. That's amazing. So 27% compared to 80%. That is dollars walking through the doors and a cash flow enhancement for these community hospitals. The other piece of it is that now these facilities are being able to enhance their continuity of care. So while Augusta has an amazing level 1 trauma center, children's hospital, we've got all the specialists in the world. So now these community patients can also have continuity of care. They see a cardiologist on telemedicine in the hospital. Guess what? We'll be able to provide them an outpatient cardiology appointment with that same cardiologist to increase their continuity and provide a longitudinal approach to being able to take care of them. This is another view of the statistics. And the reason we show this in just a different way is that hospitals' maturity coming into the program all vary. So a hospital such as Candler County, when they came on board, had a brand new hospitalist program, really wanted to be aggressive, but they needed to enhance their skill sets. So we really started focusing on them in the emergency department. How do we keep patients in the ER before we transfer them out, right? So you have to build that partnership. But a hospital such as Wills Memorial, who has a pretty mature medical staff, has had a great administration under Tracy Hugh, we actually started working with them on how we could actually support more of their post-acute patients. And so with their support and our together partnership, they actually opened during COVID a trach unit. And so we were very supportive of taking care of those long-term vent patients in collaboration with Wills Memorial. And we've done that by supporting them, recognizing their vision, and growing it with them. Some of the other important statistics on this page here highlighted is the transfer rate, as you well have seen, and the decrease there, but also that conversion to inpatient. So one stat we really hone in on is how many patients were able to say, we kept in the ER and we converted to an inpatient, which is obviously more dollars for that hospital. And so as you can see, since 2020, when able to increase that rate from 8% to 16 up to 27% of every patient is now being converted into an inpatient at these rural community hospitals. Together, this is a partnership. It is a shared strategy. This is a win-win-win for everybody involved. We are very much supportive of what the goals are for each of these individual hospitals. We know this is a personalized approach because every population is different. Every level of service they provide is different. So we want to meet them where they're at, and that's very important for us. In this program, these rural hospitals receive access 24/7 to board-certified emergency medicine, adult and pediatric physicians, as well as critical care trained physicians. They have access to specialists as well too. So if a patient falls, breaks their hip, presents to the emergency department, say in Evans, and they need to have surgery, we're actually able to coordinate that hip surgery with Evans at our orthopedic surgeons department. We prep them at Evans so they don't have to leave, come to AU, wait for a bed, wait for days when an OR room may not open up immediately. They're able to stay in their community hospital. We transfer them to Evans, get the surgery performed, and then guess what? We want to send them back for rehab care, right? Patients want to go back to their communities, and we want to send them back to their communities for continued post-acute care. I talked briefly about the skills, but we do hone in on education and training. So we provide hands-on skills training. We also do monthly journal clubs that provide CME credits. And we also, too, will go on site to work with these hospitals for skill training. And then, of course, they have collaboration with the Medical College of Georgia, the Center of Telehealth for grants, research, and then also, too, the MCG learner sites as well. So this is some of our CEO's quotes that we partner with. I'm sure you know these names: Bill Lee, Damien, Michael Purvis down in Candler. And the one that I really want to highlight is Candler County. So when we started with Candler, they had an average daily census of around 4 to 5 patients in their facility. Now, not only we started with them, but they also had that new hospitalist group that I told you about that's jumped in, Dr. Chad Slaughter. With our partnership, as well as Dr. Slaughter and Michael Purvis's leadership, they are actually averaging an average daily census of now 20 to 25 patients, up from 4 to 5. You can see here the transfer rate decreased by 50%, and they had a net increase of margin of 35%. That kept that hospital open. And with that partnership, we're always looking at ways we can enhance what they're doing to be able to increase their skill sets and keep even more patients in Metter and in Candler County. This is just an example of what we do with education. So you can see here some of our flyers we present with our journal club. We do record it so that if you can't watch it, obviously I don't want them leaving the clinic to come watch this session. We record it so they can actually listen to it later and still have access to the CME credits. We also put on a rural-focused emergency medicine and critical care training course every year, alternates between Savannah as well as Augusta. And this year it's coming up in Savannah in February. What's next? And this is a big piece for us. We're always looking at gaps and where do we expand and how do we continue enhancing care through these partnerships. So obviously we'd love to add more hospitals to the network. We're at 16. There are definitely more hospitals out there that could use this type of service to keep patients in their communities and increase their viability. But also to services. So one big piece with Dr. Ray is the tele-OB. So we're going to be looking at how we can ensure these community hospitals have access to a obstetrician through their emergency department in case a patient shows up and needs to be delivered. How do we assist them through that and get the patient to the appropriate level of care? Telepsych, this is a big piece. Obviously, behavioral mental health is one. How can we do this to support our partner sites? And then telestroke hub hospitals. Stroke care is so important. Dr. Hess pioneered our telestroke program in 2003, but now we're looking to enhance it. And by enhancing it, what we're looking to do is create hub and hub models where patients can actually stay in rural community hospitals for stroke care versus having to be transferred to a larger facility. So we're constantly looking at ways we continue to grow, to increase skills and competencies in these rural communities to continue their viability. And I'll just sum it up. This is not just Wellstar MCG or formerly AU. This is a collaboration with our rural hospital partners, with the Medical College of Georgia and Augusta University, really driving that digital inclusion model of people connecting people through digital means.
Does anyone have any questions? I think that's our presentation. Any questions on any of these areas? So, you know, we're old, or we have a great tradition, I should say. We're large, we're innovative, and we're digital.
My own, there I am. Dr. Hess, you're not old. The school may be, but you're not. Thank y'all for your presentation. I think you said in part of your presentation that we were a net loser in our training of physicians and they go other places. Is that, I don't want to put words in your mouth, but I don't want to.
Yeah, we say this, we're a net exporter of medical
Exporter.
students.
Okay.
We generally don't keep a large percentage of our students, even in Georgia. And we like to do that.
So that, you know, in my book, that's not good with the money we're putting toward, you know, the operations of all our schools and then the money that we put into most of the GME residency programs, but I know we don't in all of them. I guess the question I would have is, do you see a way to try to fix the residency issue and getting them to stay here? And another question is, do you know of other states that may not be net exporters?
Yep.
Do they put some sort of requirement on the residency programs to make sure that the students stay in that
Yeah.
state?
Well, Florida has been very successful. You know, they went up, they're in the 20s, and their state has grown too. And I don't think that there's a requirement. It's very hard to require residents to stay. You try to get programs, and I think we try to do that very well. It's just likely if they stay in your state, the odds are they're going to stay. What Florida did, because they have a lot of hospitals at the cap. See, if you're at the cap, you have a disincentive to grow residency programs because your hospital can't draw down any funds. So what Florida did is they looked to see what they were short of, which was just about everything, just about every specialty in many areas. And then what they did is the state made a payment to the hospital of about $100,000, and that was a few years ago, I don't know what it is now, to train a resident, say, in OBGYN. You know, one of the problems we have in Georgia is we don't have a lot of OBGYN residencies, right, Chad? I mean, we have, and they're very, very hard to start. How many do we have in Georgia?
So there's 6 OBGYN programs in Georgia. And of course, you know, trying to attract, I serve as a liaison for the Medical College of Georgia to the Georgia Board of Healthcare Workforce. And every year when they do the survey, we see that information from the graduates. To your question, Chairman, it is ultimately we know why we are a net exporter. There are a limited number of residency spots. They also talk about the quality of the residencies, which I find to be an interesting aspect of it. But the practice environment also makes it difficult as it relates to medical malpractice and other aspects of just practicing in any state. And so it becomes a very complicated formula. I will say that professionally as a residency program director for 10 years in OBGYN, my mission was to recruit individuals into my program that would ultimately be just like me, stay and serve our communities in Georgia. And there is the requirement by the ACGME says that you cannot incentivize them in any way to stay in the state, right? That actually is, becomes against the rules to, pay them to stay or something else. You can't give a stipend for them. But recruiting those individuals who are from Georgia certainly makes a difference. And so as I recruited, I focused heavily on the regionalization of recruitment for the 5 residency training spots that I had at MCG. And as hard as I tried and in every way possible, I would try to get those individuals that I had the highest likelihood would stay in the state. And at best, we were talking about 50-50. And that always hurt, right? And it hurts today because you just can't make it happen. Those individuals have their own needs and they will ultimately go. You can incentivize them, and I think the Georgia Board of Healthcare Workforce does a great job to look at how not only the data collection, but how then you can do innovative things to try to entice folks to stay in the state. But I would say that the blueprint is probably within that survey that comes out annually, and they just presented it at this past meeting for this past year.
Madam Chair Penny Houston.
Did you
Mash your button.
Rural Georgia is that they always say we don't have hospitals in so many counties, but we'll never have hospitals in some of these counties. I don't think the people really realize how few people we have in some of these counties. And Gerald and I have gone round and round in this opinion. But if we're going to ever get service, we're going to have to combine some rural counties. Because you cannot run a rural county with 3,000 people. And we've got, I'm sorry, you cannot. And I've got a farm in a county that says they have 5,000, but 2,000 work at the state prison almost. And because we got a state prison, and you cannot. And I look at, but we've got to look at that. Maybe I'm trying to find a solution, because they'll never, you can't get a hospital going like Arlington. Arlington Hospital closed, but how far is it from Arlington to Colquitt, Georgia? Not far at all. You can get from Arlington to Colquitt faster than you can get from Peachtree Battle to Piedmont. I mean, with the traffic. You got to consider things like that. We've got to consider more of a regional thing. We'll never get hospitals in every county. We'll never get a OBGYN in every county. But we could surely get to when I look at this map down here in Florida, Florida. I went from Nashville, Georgia to Jacksonville to the airport. You don't see a person till you get to Florida. You might see a car or two in Folkestone, Georgia, but that's it.
Representative
There's
Perkle.
nobody. I just said my piece. I just want to say, because it's not y'all.
Right.
It's not your fault that OBs are not everywhere. And I don't want you to feel like it is. It's not.
No, I definitely don't take
Thank you. Representative Perkle.
I hate to follow Chair Lady Houston. But one of the things that you mentioned about the OB program, and I think we're going to have some, my understanding that it is abhorrent medical malpractice insurance for our OBs in the state. And that's something that we will address. I'm hoping through the governor has mentioned that before. But the question I have has to do with the telemedicine part, the main part of your presentation. This is an avenue where even when we don't have a brain surgeon, so I live in a county with no doctor, and my mom suffered a stroke, and she went to a nearby community and was able to get on telemedicine with somebody in Augusta to walk them through what needs to be done. And that way we can have world-class care in the place that we desire to live, which is, I think, is wonderful. Here's a question. 2 months ago, I had a kidney stone in another state. And when I got home, Daddy said, did they treat you okay with your insurance? I said, Daddy, I don't care. If they wanted my firstborn son, they could have had him. And that is what we think about when we have an acute situation. I don't care, just give me some help. But in the light of day, somebody got to pay for it. And in rural areas, we looked at an earlier thing where 22% of the people in rural Georgia do not have health insurance. So if they get online with you, somebody has got to pay. does this cause additional problems for our rural hospitals with a heavily uninsured population?
Yeah, that's a great point. And a lot of times we get misperceptions with our leadership around what the payer mix truly is in some of these community counties, excuse me. And what I will say is this, is that yes, there is an additional cost to do this service. It's a professional, what they call professional service, right? The great part about it is if that situation occurred, it's a self-pay patient, no insurance, they come to X, Y, and Z rural hospital, they have to do telemedicine. Well, if they didn't have us for telemedicine, then obviously chances are they're probably going to a larger tertiary hospital. Now that patients' bills have just tremendously increased and doubled, ambulance pay, maybe a helicopter bill, right? We're able to intervene. And while yes, that is a self-pay or bad debt to that rural hospital, it also too equals out because it could be more. And so I think you have to balance it. I think it is a balancing act of where you have to determine, use of it, of appropriate for sending patients as a taxi service, if that makes sense, where you're just shipping out, or make the decision, I'm going to keep these patients here. This shows to my community that I'm willing to go out on a limb, take care of these patients, regardless of their payer. There's great incentives programs around the state that they can tap into. Hopefully, I know that the DPPs and things like that are coming up. And then the flip side is that community sees you're increasing your skills, right? You're increasing what you're able to provide. More patients are going to start coming to your rural hospital. And I think that's what we're seeing in the programs is while, yes, some of these self-pays may come, we're also seeing that they're increasing their patient population they're servicing because they have access now to what you just said, world-class care, and the patients don't have to leave their hospital. So I'm going to stay instead of driving 2 hours to Atlanta or to Augusta.
Thank you.
I just want to
Chairman Jaspers.
I'm sorry. No, go ahead.
Thank you, Mr. Chairman. Just real quick, I know you're on a time limit. Okay, same song, 8th verse that I've been in this meeting over the years. And I was just telling my wise friend here what I was up to, and he goes, yeah, go ahead and ask that question. Okay, so, we have talked about this residence program. We've talked about, now we've done some stuff, I think, with the Rural Development Council, the governors in the past years have done a lot of stuff on putting more people through the medical colleges at Mercer and what we're doing in Savannah. Same song, second verse. What do we do about this residency program? And I haven't seen, and I maybe have been thinking about other things, any plan coordinated from our state, whoever in this room is responsible for it, to put us all together and say, okay, this is what we need to do to address residencies and keeping our students that Chairman Hatchett talked about. We've invested $1 million in over the years in our state. And that's my question to both of our chairmen, if this is something we need to look at specially or with you or with the Board of Regents, whoever, but we're going to be here 5 years from now, the same old damn thing. Listen to this if we don't do something about it.
Great question. The Board of Regents did have something called the Great Committee, you probably know, and they created about 790 positions roughly that are still, which helped. But as you can see, we went from 41 to 40 with that. The population grew so much it wasn't enough. And the problem with that program was a great program, but it went to virgin hospitals that hadn't had residencies. And there's not many left to do that. So now we have to look at the hospitals that have caps and go above the caps. And then do these rural surgery, like OBGYN would be great for Chad to collaborate with the hospital maybe in the Southwest, and they would do some of their training down there, and then they'd be more likely to go practice there. So there's some of these rural initiatives. We have one in surgery, we could do one in OBGYN. They have to get ACGME approval and stuff, but that's something the state could do. And then look at a Florida model where you go over the cap and then combine that with rural, because you're absolutely right. We did a lot, but we're running in place. We're just not making any headway because the state's growing so fast.
Yes. From you or whoever with some specific, either their monetary, through the budget or whatever, that this group of people want to see done, the citizens of Georgia want to see it, I think we need to either, in the Board of Regents here, whom all of us know here, I think we just need a little direction in how we need to go about doing this. Thank you, Mr. Chairman.
Thank you. Representative Bentley. Stinson.
Thank you.
And
Thank you,
we're
Mr.
cutting off right here.
Okay, thank you, Mr. Chairman. I'll be very brief, and thank you for your presentation. I recall during the peak of COVID in 2020 and 2021, in Miller County, it was the only hospital that had a skilled nursing
Pharmacy.
facility that had the trach unit. I heard you mention trach. Is Miller County no longer the only one in the state that has those services now?
So Wills actually partnered with Miller to learn the Miller model, and it's now effective in Washington, Georgia at Wills Memorial Hospital.
great,
Yeah, it's a great program, and it has really enhanced. So they have one obviously down at the southwest corner and now more towards the northeast side.
Okay, great. Good to know. Thank you.
Dr. Hess, thank you, in Medical College, Georgia. We are moving on. We have pharmacy benefit managers and their role in drug spending, and Michael Power will introduce everybody.
Just real quick, there's a backpack up here. Did this belong to y'all? No? Okay. All right. Good afternoon. Michael Power. I'm with the Pharmaceutical Care Management Association. First, I'd just like to say thank you for the opportunity to be here today and talk to you guys about an important issue, which I know you are all very familiar with, as Georgia has been very active in this space the last number of years. I would like to sort of start this conversation with a point. There's a lot of conversation out there about PBMs wanting to be, or in the business of putting out our independent pharmacies out of business. And that's really not a role that we like to see ourselves painted in, or a role that we see as important across the country, especially as we're trying to serve lives here in Georgia. Independent pharmacies are critical to serving citizens in the state and making sure that they have access to medications that they need to live their lives. And so just want to sort of start there, that point. So real quick, I'll try to highlight quickly, what a PBM is. We've generally across this country been defined by a lot of other entities, not ourselves. So I'll try to get through that real fast. To really quickly touch on Georgia's activity the last couple of years in the PBM space. Talk about ERISA. We've had some questions from a number of members of this committee and across the state on what is ERISA and what does it mean and how can state laws impact ERISA plans. And so we'll have that conversation at somewhat of a high level, but happy to take questions as they pop up. And then sort of what tools PBMs have to try to help the independent pharmacies as well as those folks who live in sort of the rural community across the state. And I didn't say this at the beginning, but if there is a question that pops up in the middle of this presentation, please, unless the chair objects, please feel free to ask. If not, I can wait till the end and we'll address all the questions that we get to. So, what is a PBM? There are 73 full service PBMs that operate in this country. There's a handful that operate from coast to coast. There are a number of PBMs that operate more geographically, and then there are PBMs that still operate across this country, but they might offer a different suite of services. So we range from PBMs that offer maybe just claims processing, some that offer claims processing, formulary management, specialty pharmacy, and then we have the large PBMs, which you are all very familiar with, that are integrated with a health plan. And so it does range that spectrum. Each business does develop their model based on what they think is the best approach for them, and then they go out and try to get business. Our companies are third-party administrators. So every client that we represent, every live that we cover in this country, about 275 million Americans receive their prescription drugs through a PBM. All of that is bid through an RFP process that is competitive. And it is also important to note new businesses are getting into this space like Amazon, as well as Mark Cuban with his Cost Plus program. And so it is a competitive marketplace, and all of these PBMs not only compete for these contracts on the services that they can provide, but they also then compete with each other on the costs of the overall program to the person paying for that plan. So why hire a PBM? It is important to note there is no state, federal, municipal, county law anywhere on the books that requires anyone to use a PBM. PBMs were originated really in the 70s to manage claims because as Americans started to use more prescription drugs, had more access to insurance, The number of claims that needed to be processed really accelerated. I think the 2020 data said over 4.5 billion prescriptions were filled in this country. But if you escalate that, when you look at moving from a 30-day fill to a 60-day fill, it's more like 5.3 billion prescriptions are filled in this country on an annual basis. And so our role started as claims processing, but over time, these companies evolved to provide more services to benefit their plan sponsors. This is just a quick snapshot. And again, I am trying to run through this to sort of get to what we try to do in the rural community, but this is sort of a snapshot of the breakdown, who are sort of those payers. So you have Medicaid, Medicare, self-insured plans, and then as well as a commercial marketplace. Unions and trusts also hire PBMs to administer and manage their prescription drug benefit. And so it is sort of a wide array of groups, the state health benefit plan, as well as others that use a PBM to manage that benefit. These are, I touched on this in the earlier slide, these are sort of the tools that PBMs have that they offer, claims processing, formulary management. Many PBMs do have a template formulary, but in that RFP process, it is up to the plan sponsor to pick sort of that design of that formulary. Do they have 1 tier, 4 tiers, which drugs are on tier 1, which drugs are on tier 4, on and on and on. And so the plan sponsor, either using a third-party consultant or managing it in-house, has the ability to sort of dictate every element of this plan. In Alabama last year, there was a presentation by Yellowwood. I think we're all familiar with that company down in Daphne. They actually hire 2 PBMs to administer their prescription drug benefit. And we're actually seeing sort of more of that happen. PBMs are competing. We're seeing plans use one PBM for a certain set of services and another for another if they are offering them a better price to administer that benefit and also manage the lives that they cover. This is just a quick snapshot of the prescription drug. You'll see sort of the breakdown of the spend. And then on that far left, you'll see that PBMs, through the services that they provide, do equate for about 6% of that drug spend. And that could be either using a traditional fee-for-service model and having fees on claims process, things like that, or some of the smaller employers in the state use spread pricing to help average out their costs across their year and budget and plan accordingly. And so depending on which model a plan sponsor chooses, our spend or our percent of that drug spend is about 6%. So Georgia specifically, I pulled this information off the Kaiser Family Foundation. I think the American Association of Health Plans actually has 2023 data, but I wanted to use sort of an unbiased source, if you will. And so this is sort of the snapshot of the coverage types for Georgians across the state. The employee sponsored plans actually has increased. Hopefully the Kaiser Family Foundation will update this, but I think that's due large in part, Georgia has been the number one place to do business for the last 12 years or so. And so we've been recruiting new businesses. And as a result of that, we are bringing in more businesses that have self-insured or fully insured plans for their employees. But here's just the full snapshot of insurance types across the state. This is a PDF document. I do have this available. I have a bunch of handouts, but I knew we were sort of behind schedule, and so I didn't want to waste time passing those out. But this is sort of a snapshot of Georgia and what this is 2023, what it looks like by using a PBM here in the state. The 2 numbers that I want to highlight is that PBMs cover nearly 9 million Georgians with prescription drug benefits. So that's that's probably what 76, 77% of the state, and that's going to reach every community in this state and cover and touch a lot of families and lives. The per person savings by using a PBM, and really it's sort of future cost avoidance. We continually see healthcare costs rise every year. Most recently, I think the COVID-19 pandemic is going to drive a huge increase in premiums and insurance, but that's due in part or large because we had to change a lot of practices to respond to that national crisis. And so as a result, that's going to put pressure on insurance. But you'll see a per person per year savings when using a PBM is about $1,000. So that's, every citizen in the state that uses a PBM has that sort of a proportion of that money, depending on where their insurance comes from, in their pocket to use to do whatever they so choose with. Any questions at that point? I kind of ran through those slides pretty quick, but I know our focus is more on rural issues and I didn't want to.
Thank you, Michael. I appreciate that very much. Do we have any questions from the committee? Okay. You're recognized, Darlene.
Thank you, Mr. Chairman. I actually have a couple questions, if I could. How do you determine which drugs to include on your formulary? Because I have a lot of constituents, and this has been something that's been repeated and is coming in more often. prices seem to be changing. I know you talk about savings, but in actuality, I have constituents and even myself, my drugs have gone up, some of them by 50%. However, I've heard from pharmaceutical companies that their costs have actually gone down. So where is the difference in this money going? There's an issue here of what I'm seeing here, the percentage that goes to the pharmacy, your slide that said this much goes, it's back a couple. That's different from what I'm hearing from local pharmacies. It's different, and maybe it depends on the PBM and who owns it, and if it's part of a drugstore. I'm just telling you, I hear a lot different from my constituents.
Thank you for the question. So PBMs generally use an independent third party called a pharmacy and therapeutic committee, which is made up of medical professionals, was from doctors all the way down to physician assistants, to evaluate first the safety and the efficacy of a drug in its use to make sure it's appropriate for the treatment being prescribed. And then they will go with the plan sponsor and look to see, how does that fit in sort of their model and their structure on their formulary. So whether you place that branded drug on tier 1, or if there's a generic equivalent, they place that one there. The second issue, and I think you've touched on, or you brought up, dealing with the price of prescription drugs, there is sort of a little more devil in the details there. And if you look at Drug Channels and Adam Fine, he every year puts out a report on increasing list price of drugs and then the decreasing net price. But what you will see historically is the list price increase is still larger than the net price decrease. So which he talks about the bubble. So really, while drug companies come out here and say we are reducing our net price of drugs, the list price of that medication is actually raised higher than their net price.
Okay, this seems sleight of hand, sorry, but that's what it is feeling like.
Sure.
And that's what I hear from my constituents. There's a concern, is there a connection between making these decisions and ownership of the pharmacies or pharmaceuticals of how the pricing is done? It's an issue. I will tell you, drug costs have become a major issue at all levels. And just to be full disclosure here, I'm a payer, so I do get into the weeds with this. And I can't match up what I see with what I'm seeing in this presentation. Thank you.
Thank you.
Thank you. Representative Stevens, please.
Thank you. Am I on? Thank you, Mr. Chairman. You are correct. There's 73 PBMs, but there's really only 3 in Georgia that process about 97% of the claims. And herein lies part of the problem. Those 3, Caremark, Optum, and Express Scripts, also are integrated with the insurance company. So that is the insurance company to the PBM, all the way down to the patient. Now, the PBM also owns if I'm correct, the mail order houses and also some retail pharmacies. Now, what we've got with the MedPAC report says that because of the integrated pharmacies, and in their report, they say that they pay significantly higher prices to the pharmacies owned by the PBM than to pharmacies in general. So I guess the question then comes down to, why are we not paying all pharmacies the same rather than your own mail order house? And shouldn't this conflict be gone just eliminated?
Appreciate the question. And just for a point of clarity, in the report, when you're saying who's the they paying the
MedPAC report, they're saying that the pharmacies that are being paid, that are owned in this vertical integration from the insurance company, PBM pharmacy, that those pharmacies owned by the PBM are paid significantly higher on all cases than the local pharmacies.
I would have to take a closer look at that report. I will say, from data that CMS has provided in Medicare, where they looked at drugs that were dispensed either through a specialty pharmacy or a hospital pharmacy setting, and this is CMS's data, this is not ours, they have found many of those drugs are being dispensed at a rate much higher than their list price, sometimes 200 and 300% over the list price that a drug manufacturer may charge. And that is a drug that's being dispensed in a hospital setting. So I would have to see, I'd have to take a deeper dive into this report. That I'm familiar with it, but most of the data that we've seen coming from CMS and other sources sort of indicate the other way around.
And just for a point of clarification, Mr. Chairman, if I can, if you'll just point to the source of Medicare Payment Advisory Commission, the Medicare and Healthcare Delivery System, Chapter 2, July 2022.
Thank you. Sorry, I was trying to find my pen. I guess I left it back there.
Representative Higgins.
Am I on? Okay, thank you. Thank you for being here with your presentation. I just echo what I've heard from Chairman Taylor and Chairman Stevens, that I don't know what report he's referring to, but I hear from my independent pharmacies regularly that they do not feel that they are being reimbursed adequately for the PBMs that their customers are a part of. And so I would definitely be interested in hearing more from you when you have that information about whether y'all are reimbursing the independent pharmacies at the same rate that you're reimbursing your own pharmacists. But that wasn't my question.
Sure.
But I would like to have that information. My question is, my independent pharmacies, and like most legislators in here in the rural area, most of my pharmacies are independent. We don't have a lot of chain pharmacies in our area for our constituents to go to. So these small independent pharmacists are very important to us so that our constituents can get the pharmaceuticals they need to treat their different ailments. One of the things that I've heard multiple times from them is that about the monopoly. They keep saying the monopoly. And I assume that they're talking about the three big PBMs that do most of the work that Chairman Stevens referred to. Is there an FTC investigation going on, or was there an FTC investigation going on about our PBMs and the monopoly that they may or may not have on pharmaceutical care? And could you just address that? Thanks.
Sure. So a couple things there. So it is important to point out that only one of the fully integrated PBMs actually has retail brick and mortar pharmacy. The rest might have a mail order pharmacy or a specialty pharmacy, but there's only one company that does offer a brick and mortar. The rest operate like Walgreens, Kroger, Publix, all the other locations operate on their own. The FTC has a long history of investigating PBMs and the mergers that have occurred over the last 20, 30 years. There's actually a professor out of Wharton School. He is a doctor. He has a PhD. He is the director of healthcare economics at the University of Wharton, and he just recently wrote a book about this. The FTC has looked at PBMs for nearly 30 or 40 years, and each time found that PBMs are operating in a competitive way. There is a current investigation that is going on by the FTC, the new commissioner, Lena Khan, and she came out with a statement earlier this year, I think in September. So they've had data from the largest PBMs. I think they started collecting that data in January of this year or earlier this year, late last year. And her statement just simply said, we're going to disavow all the work that the previous FTC commissioners have done. And that's a lot of years of peer-reviewed work that they simply just said, we're going to disavow, but then they didn't come out with any new statement or any new findings on PBMs. And so it does beg the question, if you've had a lot of very intelligent, bright minds investigate this, and the best you can come up with is we're going to disavow and nothing new. I think there's more work to be done there by the FTC.
President Noah.
Thank you. I've got a question that's kind of convoluted, if you will. I've got a couple of health plans that have been looking at different captive arrangements on group health insurance. And they were telling me that they could get some of their diabetic medications shipping directly from Canada to the members or the patient's home. Now, number one, the FDA is not involved in that. And how can our pharmacies or how can our Georgia companies compete with something like that? Do you have any insight into that, or?
I don't have since that's sort of as you mentioned, the health plan side. I do know, like during the Trump administration, there was a lot of talk when the drug manufacturers would not come down on their cost of insulin about importing those drugs from Canada, and there were a number of states that looked at drug importation. I don't think Georgia had a bill to deal with that.
Well, no, we don't.
So that's
or
really
we
all
haven't. But I've got some plans telling me that they have the ability to do that now, and that just doesn't seem right to me.
No, and most of our companies that do operate like a specialty or mail order pharmacy, they're all over. I mean, there's a number of them here in the state of Georgia. So we're not talking about shipping products from Canada, Mexico, anywhere like that. We have facilities here in the state and across this country that can ship those products. if
No, but
needed.
this was particularly saying shipping from Canada directly to the member's home, and that's just what I was.
Yes, sir.
I
Yeah.
wasn't sure that was kosher.
No, and that's, again, I think a number of states looked at that in 2021, 2022, but I don't think anything.
Yeah, Georgia's not one of them,
Yeah.
I don't think. Yeah, okay, thank you.
Thank you. Chairman Hatchett.
Michael, thanks for being here. So I've received probably 10 different questions that people have asked me to ask on text, but I'm not going to ask any of them. In your presentation, you mentioned some sort of committee or review panel that looks at, I didn't hear exactly what, it's made up of.
It's a pharmacy and therapeutic committee, sir, and it is comprised of medical professionals, from doctors who are expertise is in that, in sort of, the medical space that drug is looking to treat, all the way down to, physicians, assistants, and
So
things like that.
so what do they do? What does that committee do?
And so they review, on an ongoing basis, they review drugs that are on market, they review new drugs that are coming to market to make sure, medical knowledge doubles, I think, every 90 days, or maybe even less in this country now, or around the world. And so they are constantly reviewing to ensure that the drug is the right drug for the treatment that is needed.
So that committee, if I go to a doctor and the doctor prescribes a certain medication for me and I submit it and it goes to my pharmacist and my health insurance plan is, the drug portion of it is through a PBM, the PBM has the ability to change that medicine based on what that committee found versus what my doctor and pharmacist recommend for me?
So no, that process occurs before, during like sort of the plan design phase, right? So when the plan sponsor of that plan and the PBM are working together to design the benefit package that works best for the plan sponsor, that is when that review is done to ensure that the drugs being offered on that formulary, offered to the patients and the lives they covered, are the right choice for that use.
So they have the ultimate decision as to whether I get the medication my doctor prescribed for me or not.
It would come down to, again, we're a third-party
And I'd
administrator.
have to, either the insurance would cover it or I would have to pay for it.
And there are processes by which those decisions can be reviewed, but that again is sort of a process that established between the plan sponsor and the PBM.
There's a fundamental issue there that I have a problem with, and that I pay a premium for insurance coverage and I pay a physician to take care of me. I would think that the insurance would somehow, back the decision of the physician. And I'm really worried that our insurers and our healthcare insurance companies, PBMs, whoever, are practicing medicine, and they're totally controlling the health care that we all receive, and our physicians are it's almost like they don't matter. That's my
Is it okay
concern.
if I just respond real quick, or it's up to the? Is that okay? So I appreciate your comments. It is important to note that when you look at specific drugs that are used for certain treatments, there are, in most cases, a couple brand that might be an option, right? Or there could be a generic that's available, generic that could meet the same needs of that program. Or now we're starting to see the use of biosimilars, and there's now cell therapies available for folks with diabetes, and so we're starting to see more options that exist. To get to your question there, is that in the plan design phase, when a plan sponsor is designing their program that they're offering to the lives that they cover, whether it be the state health benefit plan, they need to see which drug manufacturer is going to give them the best price for the medicine that they're putting on that formulary. And that's where their input comes in. And just real quick, this is sort of a snapshot of 2022 data here in Georgia. If we were looking at a self-insured plan, your employer pays roughly $22,220 of that program. And this is sort of where the rubber meets the road, right? We are talking about people's lives, but then there are people who are paying for a lion's share of this program that are then having to make a decision with limited resources. How do they provide a quality benefit to the lives they cover and make sure that all of the lives they cover have access to it in an affordable way?
Finish.
Okay.
Thank you, Michael, for the
Thank you.
presentation.
Are we out of time? I had a couple more slides. I was happy to hit the questions, but I can stop.
No, go ahead.
It's up to you. If I'm ready, you tell me, sir. I'm at
Yeah,
your discretion.
That was our mistake. Go ahead.
No, you're fine. I'll be really quick. You all know this. Georgia has been a hotbed of legislative activity. There's about 14 regulations on the books here in the states related to pharmacy benefit managers. It goes on from anti-steering legislation. So basically, a PBM can't put on the back of the insurance card, this is the pharmacy that is associated with your healthcare plan, all the way to some transparency provisions that were most recently adopted in House Bill 946 in 2020. That bill included a lot of provisions there that we are complying with. We're providing all that information to the department. I'd encourage you, for the information that is available, to go look and see. With the information that we're providing, it's millions of lines of data, and hopefully it's millions of lines of data, so it won't give you clarity, but hopefully it'll help you understand that we are trying to comply with the law in the information you requested. This last session, we had 2 bills at play. I'll move on from that because I know we're limited on time. Touched on this slide here. ERISA, this is where I'll stop because I know we're probably out of time and I'm probably annoying all of you by still being up here. But I just wanted to hit on this point. So this has come up a lot in legislation that we've seen here in Georgia and legislation that we've seen here in country. But ERISA is the Employee Retirement Investment Savings Act, which was founded in 1974. And the idea of this program is a federal law that essentially would allow a plan sponsor, no matter where they live, no matter where no matter where the plan originates from and where their employees live, to provide the same quality of benefit no matter where they are in this country. So if your plan is originated in Texas and you have employees covered here in Georgia, you would be allowed for your employees, if they needed to access their medical benefit, to receive the same level of care and payment for that care that they would if their employees were based in Texas. And so we've seen a lot of activity in this place. There was a Supreme Court decision in 2016 related to a Vermont law and reporting requirements. The Supreme Court upheld ERISA preemption, saying that the Department of Insurance can't require an ERISA plan sponsor to provide any information back to the state. And so that law is still standing and that decision is still upheld. That decision is still upheld by the Supreme Court. This is the decision that's given us a lot of problems recently, Rutledge versus PCMA. What they did in Arkansas in Act 900 was essentially establish a fee, an increased dispensing fee for independent pharmacies. We challenged this. We won it at the local level, but then we lost it at the Supreme Court. And essentially what the court decided was that states are allowed to establish fees because they're just like taxes. And so if a state wants to increase a dispensing fee on their plan sponsors, just like a tax, they're allowed to do that. And so this Arkansas Act was upheld because ultimately the person paying that increase in dispensing fee is not the PBM, it is the plan sponsor. So it is the businesses in the state that are having to eat that cost when they provide insurance to their employees. And then this is where I'll stop on ERISA. Recently, there's a very recent decision in Oklahoma 10th Circuit Court. It was a unanimous decision. There was a all payers legislation that was filed and passed that dealt with Medicare preemption and ERISA preemption. The oral proceedings happened earlier this year, and the 10th Circuit Court came back in a unanimous decision opposing the law or appealing the law, saying that ERISA preemption stood and that these elements that they were trying to attack in plan design were preempted under ERISA. Oklahoma is going to challenge this decision or has already started that process. And so this one there's more to come. And I will stop there as I've gone over time. Happy to take any more questions if there are.
No more questions from the committee. Thank you, Michael.
Thank you, and I appreciate you guys humbling my presence. Thank you.
Next, we have the Council on Aging, Maureen Kelly, Legislative Chair.
Good afternoon. I am not Maureen Kelly. I am Sharice Bird from the Georgia Council on Aging. So our legislative chair cannot be here. So I'm going to stand in her stead. But with that being stated, I'm going to try to be brief and get to the main points. So we're going to talk about aging today in our rural population. And again, the Georgia Council on Aging was created in 1977, basically as an advisory capacity for the General Assembly, for the governor, and for our department agencies as it relates to, again, advising on aging issues. And so from that, the Coalition of Advocates for Georgia's Elderly, or COAGE, was also created to provide additional advocates. So currently there are individuals, organizations, and businesses of approximately 700 people that make up COAGE. So I apologize for the smallness of the print. However, what this basically states is, as a state, we're getting older, okay? And so what this says is, by the Georgia Rural Health Innovation Center, is that approximately 14.6 of our population is 65 plus. So if you look at the red line that will be consistent through these slides, you have about, I think, 1.5 million, I believe, that was 60 plus, and basically is going up to almost 2.65 million projected by 2040. The blue line looks at those who are 65 and older in terms of increases in population. And then the olive or the green line are those who are 75 plus, a little bit under 500,000. But you also see, again, the increase as it relates to 2040. So specifically for rural areas, basically will be an increase in population from 60 of those 65 and older, from like a 19% to a 22% increase as we continue to age. Here it shows the 5 top populous rural counties as it relates to population aging. And so with that being stated, again, as we all know, we have more and more baby boomers who are now coming through our system, right? Here in Bullock County, there's a younger population. You've got the university here. And so with that being stated, they're about 7% of the population in Statesboro that's about 65 and older. So what this slide essentially does is show us the various challenges. So the first symbol that you see is essentially mobility and access, limitations as it relates to transportation. Then we have healthcare challenges and access. Typically transportation, housing follow 1 and 2. We have some seniors who are on a limited or fixed income. We also have some food deserts and transportation deserts, and then also mental health, social isolation as we look at mental health with older adults. And so one of the things that's been echoed throughout today are workforce challenges and shortages. And so with that being stated, I won't reiterate that, but essentially finding more healthcare workers, whether it's at the physician level, nurse, or certified nursing assistant, is basically more challenging also as our workforce retires. So here are the priorities for COAGE for 2024. Again, there are about 700 individuals, organizations that vote on these priorities. We have one budget priority, which is 10 million in funding for home and community-based services. And then you have a leftover, which is at the bottom from last year, improvements to assisted living, and then the multidisciplinary teams for adult abuse, neglect, and exploitation, and medical aid and dying. So the 10 million in home and community-based funds is non-Medicaid dollars allocated to help those statewide to remain in their homes and communities. And as it indicates, there are currently about 12,000 people on the wait list for services in this state. And again, this would help to clear the wait list. So the multidisciplinary team, I'm going to start with Adult Protective Services, because Adult Protective Services investigates allegations of abuse, neglect, and exploitation within the state. And so with that being stated, this will be a multidisciplinary team that's encompassing of the district attorney, law enforcement, and all these other collaboratives up here to basically create a structure to help prevent elder abuse. The most common form of elder abuse is financial exploitation. So with that being stated, there are about 5 MDTs within the state now. This would not require all 11 circuits to create an MDT, although COAGE supports that. This is more so for providing structure. The medical aid in dying request was brought to the council this year by a representative of a family member who died from a terminal disease, which was cancer. And basically the request was, as we discussed it, to basically have a study committee to review this. The premise is more along the lines of self-determination if someone has a terminal diagnosis, where 2 medical professionals, that person's doctor and then a third party, would agree that there is a terminal diagnosis where typically death would be imminent within 6 months, and they have no cognitive impairment such as dementia, or let's just say they're suffering from depression or PTSD, but there would be a terminal diagnosis, and that this person would be able to administer any medication for themselves if life was not going to be prolonged. Improvement to assisted living. So in my prior life, I served as a director of independent living, assisted living, and memory care communities. In the state of Georgia, we know Medicaid is more so for skilled or long-term care. And so what this slide is essentially advocating for is expansion of Medicaid for assisted living communities. And so with that being stated, the next map is basically going to give an overview, because you have a lot of personal care homes within the state that are 25 beds and less. And then also this map, which shows, the little black circles, basically indicates where all of the personal care homes are within the state. And the dark red indicates where those are living below the federal poverty level in Georgia, which is about $14,580 for a family of 1. So with that being stated, I tried to keep it short and sweet. What questions do you have?
Thank you. Are there any questions from the committee? Lisa, I'm sorry, Representative Hagan.
Okay, back to the priorities, when you're talking about medical aid in dying, what is that? Are you talking about doctor-assisted suicide? What are you?
So that is not doctor-assisted
How is it
suicide.
different?
So first of all, let me just say that the definition in the states that it's allowable, you have to be, first of all, cognitively capable. You have to have 2 doctors who agree you have a terminal diagnosis that you would die within 6 months. So with that being stated, I'm not here to debate the point. I'm just saying how it was presented to us as COAGE. So with that being stated, I'll be happy to get you additional information, but the premise behind it is self-determination.
I would like more information about that. I'm a little bit disturbed that we've got a state agency with a stated priority of legislation to allow what it sounds like doctor-assisted suicide. So please, if you would get us that information, that'd be great.
And I'd be happy to do so.
Thank
And
you.
understand this was voted on by COAGE, not the state agency. So the COAGE members decided these priorities.
President, you got to follow up.
Yeah, explain to me what COAGE is then.
So let me back up. COAGE is the Coalition of Advocates for Elderly. And I'll go back to the very first slide. Here we go. Second slide. And so with that being stated, it's an advocacy arm underneath the Georgia Council on Aging. And so essentially, priorities are brought to the council around about May or April of each year. And this initiative was brought to the council and was voted on as one of the priorities that was selected for COAGE.
Okay.
Okay. Representative Corbett. Your light on?
Yeah, I'm on now. On the assisted living, a question on that. Is that regulated under CON? If you take Medicaid, if it's over 25 beds, would that take a change in CON to do that?
So with that being stated, at the development, possibly, I know we were regulated, and I say we because in my prior life, I served as an executive director. That was all done through the Department of Community Health, Healthcare Facilities Regulatory Department. However, there's lots of discussion about the CON process, but I'd have to get more information for you in terms of, at this time, there's no Medicaid dollars in the assisted living world.
Representative Stinson.
Am I on? Thank you. Ms. Byrd, back to the slide relating to the yes, this slide. And you referenced the COAGE. Who actually appoints members to the COAGE?
So with that being stated, it works in the sense of COAGE members are not appointed. COAGE members can join the organization by paying a fee. However, members of the Council on Aging are appointed by the governor, the lieutenant governor, and department heads such as the Department of Human Services. So the Council on Aging is appointed. However, COAGE members are advocates throughout the state.
And so those advocates came up with this particular suggestion or recommendation?
That is correct.
Okay. Thank you.
You're welcome.
Representative Taylor.
Mr. Chairman, I just have a quick question. Are there programs available for the elderly to have a family member help keep them at home rather than going into a facility? I have a constituent that had asked about this.
So with that being stated, you want to access the local area agencies on aging. So for instance, in Statesboro and Bullitt County, that's Coastal Regional Commission or the Coastal Area Agency on Aging. Basically, you would go through your aging and disability resource connection to be triaged to determine if they meet eligibility for services. And with that being stated, they would see what programs or services that they are eligible for.
And could a family member receive the payment for providing that service?
So that would require a little bit more conversation. There are not a lot of programs now in which the caregiver would receive services. That actually was a priority that was brought to COAGE this year. However, it wasn't voted upon as a priority. So I could get you more information about that.
I know some special arrangements were made during COVID, and I did not know if that has ended. I know there was a program for actually children that were disabled, and a family member could take care of them, but that's ending. And I didn't know if we had something similar for the elderly. Thank you.
At this point, to my knowledge, that is sunsetting, and the reimbursement as it relates to a family caregiver is nominal.
Thank you.
Thank you. We have a special request from the chair that you show the last two slides.
The last two slides. Okay, so this is, again, the community showing federal poverty level throughout the state, as well as where personal care homes are located.
Okay.
Okay. And so last two slides, let me back up. That would be improvements to assisted living.
Okay. That's good. Thank you so much for the presentation.
You're welcome.
You will introduce to Kaiser. Okay. Our next presenter is Kaiser Permetti Military Veterans Employment Program, Shay Ross Smith, Director. And she'll introduce the staff.
Thank you guys so much. I know that we're in between you and the speaker, so we will be brief in our comments, but definitely wanted to talk to you guys today about something that KP is taking part of in Virginia, a program that we are part of in Virginia, and it's a unique idea, creative idea on how to fill workforce issues. So first and foremost, I'm Shay Ross Smith. I'm the Director of Government Relations for Kaiser Permanente of Georgia. And I have my colleague here, Jamal Lofton, with me. He is from our Virginia market, takes part in this program, and he knows a lot more about it than I do for sure. I'm going to talk to you really quickly, briefly, high level about the program, and then I'm going to let Jamal take over and really give you an in-depth look on what the program does. What Virginia did is they, like us, and you guys have done, the legislature has done a phenomenal job in expediting military licensure, veteran licensure, as well as spouse licensure. This program would be in addition to what you have already done, a cherry on top of the good things that the state has done for veterans leaving the military, coming into the civilian space, looking for jobs. This is the enabling legislation. I wanted you guys to have the language just so you could see what Virginia did. The language allows military medical personnel to practice medicine under the supervision of a physician or registered nurse, and they are not having to go through the traditional education, civilian education, once they leave the military. And that's basically the whole program that Jamal is going to speak on. I will say that this started as a pilot in Virginia, and then it was successful, and they put it into code permanently. And KP is a part of that program in Virginia, and our workforce issues at KP Virginia have benefited from this program, from this language in Virginia code. I'm going to let Jamal take over.
All right, good afternoon, everyone. Thanks for having me. Thanks, Shay, for the introduction. My name is Jamal Lofton. I am a prior hospital corpsman in the United States Navy. And what that means is, if you think about modern day physician assistants, they originated from hospital corpsmen in the United States Navy. Upon joining the Navy, I was a hospital corpsman for 6 years. If I would have left the Navy at my 6-year mark, employment would have been extremely hard, would have been difficult from the skills that I gained in the military. So I'll tell you about my military skills gained. I was EMT certified in the military. I'm a combat medic. I deployed twice. Intubation, extubation, IVs, the whole 9 yards. A modern day physician assistant. If I get out, maybe a certified nursing assistant, maybe, right? So I went on and got my education in the military, and eventually retired in 2018. Why this program is really important is because you have military members, and I know the state of Georgia, because I remember my boot camp class had a lot of Georgians in my boot camp class. This is my first time outside of Atlanta in Georgia, but I remember where all my friends were from. They were from Valdosta, Barney, Port Wentworth, all areas outside of Metro Atlanta. And when they were hospital corpsmen, if they got out, no meaningful employment. So Virginia started this program to basically transition these individuals from medics in the Army, hospital corpsmen in the Navy, med techs in the Air Force, to be able to receive meaningful employment when they transition out of the military. So I'll go right to the process of what Virginia does. Basically, the state of Virginia, they have three employees that run this program. They recruit for various agencies in healthcare in the state of Virginia, and they do a general scope of practice, saying, hey, here are the skills, excuse me, here are the skills that you attained in the military, and here's how you can transition those to a civilian organization. It's done through a general scope of practice, so the actual healthcare organization has to sign off on the credentials. So it's a perfect marriage, if you will. Here are some of the healthcare positions that we've transitioned into. We also know that Georgia, like many places in the U.S., have a growing gap with healthcare coverage. So this has proven to be an extender to fill these gaps on healthcare coverages through various job careers.
And so let me just give you a holistic view of this program. Just like Jamal was stating, when he was in the Navy, he was performing services at this level, received his education through his Navy experience, and then when he left, he would have had to re-go through that education to enter the civilian workforce in healthcare. This program allows Jamal not to have to do that. With the skill set that he receives in the Navy, he's entering the workforce at a level where he is not having to go through a credentialing process, a re-education process. I'm going to go back to our slide that had the list of healthcare positions. Emergency techs, medical assistants, this level of provider, these individuals are not having to go through an education process. This could be 2 weeks. This could be 4 months. There's a cost to get credentialed. They're entering the workforce directly from the military. They are working within their scope of practice. We're not trying to change any type of scope of practice conversation in the state. They're working in the education that they received from the military. They're just having, I don't want to use the term expedited because I know we use that term for licensure, but it is an expedited path to getting jobs. In Virginia, the VA, Virginia's VA, Department of VA, is working with the healthcare entities to get these individuals placed in workforce shortage areas. And so there is a piece where the state is a part of this conversation, being sure the individual is being appropriately placed with the appropriate scope of practice in these positions. The final slide I want you guys to see is the outcomes that Virginia has experienced. So this program started in 2017. Like I said, it was a pilot program at that point. Since 2017, over 564 veterans have been placed into healthcare workforce positions through this program. And like Jamal was talking about earlier, a lot of these individuals have family in rural areas or from rural parts of the state. We feel like this could assist in rural workforce issues as well as workforce issues in Metro Atlanta. I'm happy to answer questions. I know that was really fast.
This one is for Jamal. What area are you working in? I saw the list of areas. Are you working in one of those areas now?
I do. I work in Northern Virginia.
In Northern Virginia?
Yes.
In which one of those capacities?
In Kaiser Permanente. I actually got my degree. So I'm a area director for KP in Northern Virginia. So I have my degree. So I am not in one of those positions.
So you're not in one. You went back and got education.
Correct.
You got the education.
Yes, sir.
Thank you. Any more questions?
Let's go.
Oh,
One quick.
go ahead.
I haven't got to read all of this right here, but I've said this for years. And to clarify, to get people to understand this, if you're a medic and you come out and you've been over in the war and you've done stuff on the field or you've done stuff in a I guess a base hospital type deal.
Mhm.
When you come out, you cannot even be an EMT on an ambulance. Is that correct?
That is correct. You probably need to get recertified.
It's insanity to me. I mean, that's the man I want.
Absolutely.
I don't want somebody that's been watching TV for 3 days and, but I appreciate y'all bringing this and I look forward to seeing it.
Chairman Green.
Thank you so much. A great presentation. When this was brought to Representative Jackson and myself, we wanted to make sure that the committee had the ins and outs of this. And one of the things that several people asked me about, where did you receive the opposition from in Virginia?
So I spoke to my colleague in Virginia who has my position for the Virginia KP market, and he was actually not at KP at the time that this bill went into effect. He was working for the speaker in Virginia, so it was a huge part of implementing this legislation. He stated that there was no opposition in Virginia, that they had worked with the provider groups, they had worked with the Nurses Association, and they did not experience opposition. We have had very high level preliminary conversations, definitely not in depth enough for me to say that there's no opposition in Georgia. But we are starting those conversations in hopes that people will see that there is a huge workforce issue in the state, and this is a creative idea to assist in that workforce issue.
It is a creative idea that with our workforce shortages, we really appreciate y'all bringing this before us today. I think we still have some other questions.
Chairman Dickey. Chair recognizes Chairman Dickey.
Thank you, Mr. Chairman. In my district, we have a center in Warner Robins called Vector, Veterans, Retired Military, and it's for training military to go back in various different professions. I assumed healthcare was one of them. Are y'all familiar working with our Vector Center there in Middle Georgia?
I'm not familiar with Vector, and I don't know if Jamal has had experience in Virginia with Vector, but that is not something that came up in my research. But I'd be very interested to learn more in what they do and how they could be, potentially a
Our
partner in
Vector
this
Center, I
process.
think, comes under a technical college situation, but it's counsels, trains, try to help our military transition from military to private sector, be credentialed and certified and that sort of thing. And we've expanded that place one time. So
And
I
just to
think we
kind
got
of,
some resources out there. I think I'd love to look into it a little more.
in addition to that, I know we focus on healthcare because we are a healthcare company, KP is, but you can see under these pathways that there's the MMAC qualified pathway that is specific to healthcare. But the second pathway, No Veteran Left Behind, that's outside of healthcare. That is for all occupational licensure professions. So they're looking at, HVACs, individuals who have skills in plumbing, et cetera, to kind of go around these credentialing processes that exist in states when they already have the skill set. They also have the Path 3, which is healthcare leadership for individuals who in their military service have leadership positions or maybe have a master's degree, have an education like Jamal, and can be placed in maybe even outside of clinical scenarios or jobs, but can be placed in healthcare settings with leadership potential and leadership positions.
Thank you so much for that presentation, and we look forward to working more and more with you.
Did you have a question?
Yeah,
I'm sorry.
I had a question. That's
Okay,
fine.
go ahead, go ahead.
What is, and I might have missed this, what is the difference or the scope of practice in the law from Virginia versus Georgia? I mean, why can't we implement this? How are we different than Virginia?
We can implement this. There's nothing that prevents us from having language like the Virginia language and putting it into code to allow this program. Scope of practice, we want to be sure that individuals and providers know that we're not trying to put people in positions that are outside of their scope of practice. In Virginia, how they define scope of practice, and actually at the end of my presentation, I hope you guys are getting a digital copy of this because there are skill requirements for the program, and that really outlines the skills that are needed for a person who is a veteran who's leaving the military to enter into a program like this in the healthcare space, and it's defining that scope.
Okay.
We wouldn't want somebody to be practicing at a PA level who maybe is not at that level. And I will say it over and over again, that is not our intent. We're not trying to change scope in Georgia.
Yeah, I was just interested in the difference. That was all.
Sure.
So I can give you an example, sir, to your question. So talking about scope of practice, so what we did in Kaiser Permanente is we look at what do we need for a specific job skill. Say we're talking about an urgent care tech or a clinical assistant or medical assistant. We need you to be able to remove sutures, start an IV, right? We have a list. And the entity in Virginia, the program manager, they'll match that list with the skill sets, and they'll say, okay, well, I have a qualified applicant who has done all of these skills, and we sign off on the scope of practice as the medical entity. So that's how we kind of marry up, finding the right person with the right skill sets for the job.
Okay, thank you.
Thank you guys so much. We appreciate your time.
Thank you. We're gonna take a short break.
Yeah.
We're gonna take a short break before the speaker comes.
Yeah, he's here. 5 minutes.
Love me, Jerry.
Well, you know, I'm good. Ladies and gentlemen of if y'all will come back to order, please come back to order. We have a very special person to speak to us today, and I want to give him as much time as he needs to speak to it. So if y'all will take your seats again, please. They got quiet, didn't they? I didn't even have the gavel. Ladies and gentlemen, I'm happy to introduce this individual to you. He's been all over Georgia lately, and he's an individual that cares about Georgia, loves Georgia, and he really loves rural Georgia. He was in Albany, was it, I think yesterday, I don't even know where I am today. And Mac just reached out and said, "You're in Statesboro today." But this person really needs no introduction because he is an individual that is really giving of his time, his leadership. Ladies and gentlemen, I present to you for you to listen to our speaker, Speaker John Burns.
Thank you, Dean. Thank you, Dean. Always appreciate you. And we were in Albany. And what a great group of folks you had and the team had there in Albany. It was special to see everyone and to see a great bipartisan showing of support for Gerald. And let's see, who else was there?
Bill.
Bill was there. And hey, Patty. Congratulations, by the way. And say Joe was there. So it was a great event from Southwest Georgia that we enjoyed. So you're better half outside, Mr. Chairman. You're a lucky man. That's all I can say for you. I hope y'all have had a good day. We've had a good day visiting with some great folks across Georgia the last couple of days. And yes, we were in great place down in South Georgia. I see Chaz back there. Spent the day with Chaz yesterday, and was it Cordele? No, Mr. Chairman, it wasn't Cordele. Well, we were glad to be in Moultrie, so it was a good day. We enjoyed ourselves, and again got to see some really good people, and got to spend some time on what we know makes Georgia the best place in this country to live, work, and raise a family. And we were close to Vidalia, but almost not quite there. We had a great time, and it was good to be there. So I just want to welcome y'all. I know y'all been welcomed here today, and there are several Eagles in this congregation, if you will, and we're proud to have you here, and welcome to our part of the state. Now, I just let y'all know that I'm very proud and been very blessed to have lived in this part of the state, Southeast Georgia, all my life, just about 25 miles from here over in Effingham County, where a place we call home. We've called home for a long time, my family has, and Dale and I are blessed to still be there. So to the members, we appreciate y'all taking time. I know y'all been working hard with this council and with the leadership here, providing your leadership, gathering facts. We appreciate what y'all have been doing. It's important work that you're doing here on the campus of my alma mater, Georgia Southern. Believe it or not, I got a diploma from here a few years ago. And so we've tried to change it over to Georgia Southern University, but I can't quite get that done, Annalee, but we'll work on that. But it's been great, and we want to thank our great president here, Kyle Marrero, who's done a great job with leading Georgia Southern over the last few years, and certainly someone I've grown to know very well, a very capable lady that is Kyle's right hand, is Annalee Ashley. And Annalee, thank you for your work. And Brian, it's always good to see you. Brian Harris does a great job of representing Georgia Southern. Thank you, and we appreciate you as well. And everyone at Georgia Southern who's been facilitating the events. I think we've had a couple of committees that have been around here in different areas in Statesboro and all the work you've done to make sure that our folks are being well served. as we continue to support this great university through the General Assembly and especially through the House. But, you know, I want to certainly the folks that important to me are Georgians, but the folks that are especially important to me are our colleagues. You folks have made the effort to take your time to be here. They tell me, and I think they're right, this is a very august group, Co-Chairman, very august group. I think I like that about y'all. This Rural Development Council is a bipartisan group. That's very clear from up front of rural legislators that are experts in many different areas, many different subject matters. And we also have professionals from around the state that are those same type experts. You know, that common trait that we all have, that we care about our rural communities all over this state, is important to our state, that we're also committed to expanding economic opportunity to every part of this state. You know, I always joke about South Georgia, Miss Penny. You know it's important, but I don't know, the quality of life and economic development all over our state is important to all of us in this room. It's very important to me, and we're very supportive of that. That work in the House is important to us all, and we will continue to do just that. I want to say a special shout out and a special thanks to the Dean of the House, Gerald Green. Thank you for your work way down in Southwest Georgia over to Southeast Georgia and what you've done over the years. You've served in the General Assembly representing the interest of all Georgians. And my dear friend and friend of the former Speaker of the House, David Ralston, Mac Jackson from up in Sandersville. Mac, I don't know of anyone I respect more than you. And so I appreciate what you continue doing, what you've been doing and leading in the House. The interaction between you two and the leadership that y'all demonstrate through getting things done, action. It shows that we can set aside our differences in the Georgia House, as we do often, and we work together to build a better Georgia. Thank you for what you do too. Y'all's leadership is exemplary to me and to other members of the House, and I think it's just a tremendous example of servant leadership that y'all bring to the table and y'all demonstrate as y'all work together to move this state forward. So thank you both for leading this Rural Development Council. Thank you for your work. We have a couple of other people I want to especially thank that do yeoman's work on a regular basis. One of them's here. I get to deal with him during the session on a daily basis, and that's Leo Chansey. Leo, thank you for what you do. With the House Budget and Research Office, it's very important work as you organize and help coordinate these meetings with this council. But what you do working with Chairman Richard Smith may be your legacy, though, in the House. I'm not sure. So helping lead the Rules Committee. So thank you, Leo. We are especially grateful for you and other folks. Members of the staff, thank you for what y'all do for us on a daily basis, and thanks for coming to Statesboro. They tell me that this Rural Development Council has been in place since 2017, serving rural Georgia. You know, and while a great deal of progress has been made over these years, as we all know, much remains to be done. Chief of Staff Terry England, let me acknowledge him to begin with, knows the history of the House. He helped make that history over the years. We're so pleased and very special relationship that many of us and all of us in the House have with Terry is his 18 years of service to Georgia. But for asking him, come back, Terry, and to step back into this fray as Chief of Staff, Terry, I'm indebted to you. Terry, along with former Chairman Jay Powell, along with a man we all know well and we miss every day, Speaker David Ralston, the key architects to creating this body that has made such a difference for rural Georgia that lifts all Georgians. So Terry, thank you. Thank you to Speaker Ralston. Y'all know I always like to say a story seldom told is soon forgotten. We will not forget David Ralston and what he meant to this state and what he meant to us as individuals as time goes on. They tell me that we should be very proud, and we are, because this House has led the way to ensure that Georgia remains the #1 state in the nation in which to do business for a decade. Now, I was with a group a while ago. I had to tell some of them what a decade meant, but I know Matt can count, so he knows that's 10 years. But you know, this did not happen by accident. It just didn't fall out of, it wasn't manna from heaven, if you will, just falling down. It took a true team effort. Many of you in our audience today, but many of the folks around this table is what it took to bring that economic opportunity to Georgia. Economic opportunity. But it's just one component to the great quality of life that we enjoy in our state. Another key component to that quality of life in Georgia is the availability of affordable, high-quality health care. And I know that's what y'all are down here in Southeast Georgia doing today and tomorrow, is focusing on health care as you go through your meeting time the next couple of days. Gathering what we like to work with in the House, gathering the facts as we make good policy determinations about our future. But there are also some other folks that are important to gathering the facts that are here, and I want to thank our private sector partners. I know I've seen some of the hometown health folks here, Georgia Hospital Association's here, Kaiser's here, NAMI's here. I want to thank all of you for participating and being part with the host of state agencies that are here as well. Spoke to some of them as when I came in, and different organizations that are here present for engaging on this important topic to all of Georgians. It goes without saying that we understand in the House we deal with some complicated issues, but physical and mental health care is a very complicated topic, one that crosses many issue areas like workforce development, insurance regulation, Chairman Parrish, CON laws that you're working diligently on, and licensing, to name just a few. I have no doubt that this council will take to heart the testimony you hear and the data which is presented to you today and tomorrow, continue moving us in the right direction. Again, dealing with the facts. Now, speaking of the right direction, I told you that I was very proud that this meeting was being hosted by my alma mater. And that's true. But I didn't tell you entirely why I'm so proud. You know, while Georgia Southern for me has played an important role in my life and in my family's life and of countless Georgians around this state, I believe it stands as a beacon of hope for us when it comes to health care. We recognize when Georgia's new medical school campus opens next year, it will be on the Armstrong campus, Ron, something very, very dear to you, on the Armstrong campus of Georgia Southern University, just a little ways down I-16 in the beautiful, historic birthplace of Georgia, Savannah, Georgia. So thank you, Ron, for continuing the partnership with Georgia Southern in a very powerful way. This innovative partnership with the Medical College of Georgia, Augusta University, will facilitate the training of more doctors to serve our entire state and its people. So in a very short period of time, Georgia Southern's medical campus will become an important part of proving access to high quality, affordable health care in Georgia, which I think is scheduled in the fall of 2024 to receive and begin that first class of students. That's quite an impressive timeline, and we are very proud of that as Southeast Georgians, but more importantly as Georgians, and more importantly folks in leadership that care about health care for all Georgians. You know, there are a number of folks I'll think forgetting things just don't happen in a vacuum, do they? I don't think they do. But I want to thank a number of folks that have been very positive in ensuring that this new medical campus gets off the ground in a fast process, in a very rapid manner, including our own Georgia Southern president that I mentioned a while ago, Kyle Marrero, who's been a leader in ensuring this happens. AU president, former president of Georgia Southern University, Brooks Keel, and a very special person to me and a key to these discussions has been the VP at Augusta, Russell Keene, who was also at Georgia Southern. I also want to thank some other folks that were key decision makers and implementers of this great opportunity for Georgia. And that's our University System Board of Regents, our Chancellor Sonny Perdue, for their leadership and their cooperation. And finally, Certainly last but not least, I'm going to thank all of you around this table and the other 180 members of the House and the 56 members of the Senate that saw within their hearts to vote for a budget that Governor Kemp signed that recognized the need for a new medical school and funding it through a very comprehensive budget. Thank you, Matt, for your leadership as Chairman of Appropriations. You know, for us, this medical school, in conjunction with, I'll say to you, a very robust nursing school at Georgia Southern University that is a powerful part of health care in our state, and we as individuals, is just the next step. The House of Representatives continue to work to make health care, again, more affordable and accessible to all Georgians. I think that's a pretty important mission, and we're getting there, y'all, thanks to the work y'all are doing. Whether combating maternal mortality in the House or expanding access to telemedicine in the House, this House, our House, has worked together, and I emphasize together, on these critical topics over the past few years. And I know with great confidence that we'll continue to do so as we move forward to make Georgia just an absolute better place for all of our citizens. And I'm sure the work y'all are doing with the Rural Development Council over the hearings that you'll have, especially here in Georgia Southern, will contribute much towards keeping us moving in that right direction based on the facts, and one in which we make the future brighter for all Georgians. All Georgians. I think that's the quality of life we all want our fellow citizens to enjoy, and we want to enjoy ourselves and for our families. I look forward as we get ready to go into the 2024 session in just a very few months to receiving and reviewing this council's recommendations at the end of this year. And to get ready, to be ready to take action on good policy based on facts when we go into session in 2024. I want to thank you all again for being here. You know, and I could say thank y'all for being here in God's country, but I think we all believe we come from a little garden spot that God created for us. There's nothing wrong with that. We're a little bit partial to Southeast Georgia, but we're proud that you're here. And I just want to thank y'all all for being here. And may God bless you all. May God keep you safe in your travels as you go back home. May God continue to bless this great state of Georgia and these United States of America. Thank y'all. Appreciate you all. Thank you. Thank you.
Mr. Speaker, thank you for allowing us to carry on the legacy of the late Speaker David Ralston and allowing this committee to continue to do the great work that was started in 2017. I was on this committee since its inception, and it's a great honor for me for you to place me with the Dean of the House of the Georgia State Representative and Chairman Green to work alongside him to carry on this great work that we've been doing here in the Rural Development Council. We thank you for your leadership in the Georgia House of Representatives. Thank you for being a friend of rural Georgia and all of Georgia and making Georgia one of the best states in the nation to do business in. Again, we appreciate you and we thank you. Chairman Green.
All right, that's going to be the conclusion for today. We'll start again in the morning at 9. And people, we need to stay on task tomorrow because we've got to be out of here by a certain time. It's a little something going on tomorrow that we got to take care of for Georgia Southern. But tonight we're going to be at Ogeechee Technical College in the Jack Hill building. And the time that we need to be there for the reception is 6:30. Dinner is at 7 o'clock. Transportation will be provided. Voice. Anyway, Ogeechee Technical College tonight, Jack Hill Building. The reception is at 6:30. Dinner's at 7 o'clock. Transportation will start from the Holiday Inn Express at 5:50, and we'll run people over to Ogeechee until 6:45. Then the buses will start back at 8:15 and run people back to the hotel until everyone that needs a ride is gone. So we will see you then on that. But let me say, Brian, thank you so much for all your work. Brian Harris has been right there to guide us on everything, and we couldn't ask for a better person to help us through this at Georgia Southern. It's been a great day. See you tomorrow.